Good afternoon, everyone. We're going to call this work session in Division 3 to order. Today is Friday, February 21st, 2025. Our purpose today has been published in the calendar, so it's been duly noted publicly. We are Division 3 of House Finance. We have a 1 p.m. work session today. It's a budget work session for the Division of Medicaid Services. For the record, I'm State Representative Maureen Mooney of the town of Merrimack. Our chairman, Representative Jess Edwards, could not be here today. Just a few budgeting notes in general. I just want to point out that what we do here in House Finance Divisions is recommended to the full finance. So though we may take action or give motions and so forth, ours are just recommendations to the full Finance Committee. As we go through the budget process, we are obliged to have a balanced budget. That is, we cannot spend more than we take in. And that can be located in RSA 9:8-b. Compatible with that is House Rule 48, which says that we work in close collaboration with the House Ways and Means Committee in order to know just how much it is we can spend. For today's presentations, we'll make it very clear what page number we're working off of, what accounting unit we're working off of. You'll notice already in our packets, I think we're going to cover probably close to 10. And what sections. Also want to make mention of the incredible resources that are found for this division, all the divisions, House Finance, and the entire budget process, both on the Department of Administrative Services website and through the General Court website, the LBA, Legislative Budget Assistant. Everything that we work off of, documents large and small, what you may think is relevant, what you may think is not relevant, can be found on those two pages. Incredible resources for everything that we look at here in Division 3, as well as the other divisions. As we go forward today, I'd like to have the presenters talk about prioritized needs, naturally, as best you can, with this sort of notice. So that is related to what DHHS wanted and what the governor perhaps funded in her proposals. Also, vacancy rates, if we could discuss that as we go along presentation-wise. I'll be taking no motions today, but I do encourage the members to take notes, clear notes, in terms of things that may catch your eye of what may be discussed or amended or proposed later on at future work sessions. Deadline, just want to remind everybody for Division 3, we're looking at a March 27th, correct me if I'm wrong, but a March 27th target in terms of getting out our amendments to House Bills 1 and 2.
So I've since learned that March 27th may be a possible session day. So the other analysts are telling their divisions March 26th. So I would assume that for the time being.
Okay, March 26th. That's a little better. I think that's it for my introductory comments. Anything from the members of Division 3? Representative Talerski.
Thank you so much, Chairwoman Mooney. When we finished our last meeting on Wednesday, I had some questions about some Medicaid policy changes that the governor had alluded to. And we talked about my concerns about going into this informational session this afternoon without any information on policy changes. Since then, I've had a number of conversations and I've gone digging a little bit. But what happened after that session closed, well, actually, while the meeting was still going, Chairman Edwards said, "Oh, I have a document. It's really easy. It's the 5 bullet point document," which I had not seen, a number of people had not seen. I received the document. Now, it's unclear to me who wrote this document. It's not on official letterhead. I don't know what it is or where it came from, but I believe a number of us now have this document. And I guess I just want to express my concerns because I dug into the RSA 9.9:2-A, which revolves around transmission to the legislature of the budget. And this is the section that states that not later than February 15th, I'll jump ahead a little bit, the governor shall transmit to the legislature a document to be known as the trailer bill containing any changes to statutory law deemed necessary for the ensuing biennium. We know it as House Bill 2. It was recently amended to then state that the electronic file needed to be posted on the DAS website on the date of transmittal. And we have a copy of that. It's draft format. And there's nothing in this document that actually has policy changes to Medicaid that are reflected in the 5 bullet point document in question. So, number one, I'm a little concerned about the lack of transparency of upcoming policy changes that should have been transmitted to the legislature by February 15th that aren't there. We also got an email saying from one of our members in full finance saying we don't expect to see House Bill 2 or the trailer bill until March 1st. So again, that's another, I think that puts us as over a week from today. So I am really uncomfortable that we are going to be discussing significant policy changes that are going to affect tens of thousands of Granite Staters and their healthcare coverage without official documentation on the changes that are coming. So I guess I'll start there as a starting point for this session. And I want to thank the people who have answered my questions and concerns up to this point. But you did just state that all the documents we're working on can be found on the website. And I don't believe that the document in question is on the website. Is that correct?
Well, we can start there. Thank
Yeah.
you for your comments. That was a lot, so I want to get to all of that. We'll start with, yes, the document of the 5 points. I have the same copy as you, including the notations. This will be discussed today. I believe it originated with Mr. Lipman. Correct me if I'm wrong. And it was in discussions this morning, quite early, with Mr. Ripple, and I insisted that this very document be on the website, seeing as though we will be looking at it today. So Mr. Ripple and I discussed that at length. Do you have a timeline, Mr. Ripple, as to when the document in question, and I don't know really what to call it, but it's 5 points, as Representative Tulersky described, related to Medicaid discussion points. Has that been posted? If not, when?
It hasn't, so I'm about to put that as well as today's presentation materials online, so they'll be up within the next 5 minutes.
Within the next 5 minutes. As for House Bill 2, now I've not been here forever. However, it seems like a reoccurring issue that it doesn't come out at simultaneous with the governor's budget presentation, despite the RSA you quoted with a specified date. So in terms of how to go forward with that, I think it's comparative to other years, previous years. And my thought is we just have to wait that out. Now, a correspondence did come through today, I don't know who it was from, that OLS will be working on the finalized version next week. So it sounds like things are moving. But as for completion, I don't have an answer. Mr. Ripple, do you have anything to add to that?
We've heard from OLS that they plan to have the draft, the bill ready for introduction by the end of next week.
And is it your understanding, like mine, that this has happened in previous cycles, that House Bill 2 is delayed?
Yes, there usually is a delay because they go through the document that the governor's office provided and they make sure that all the references are correct, et cetera, and they put it into a format that's consistent with other bills. And because it's so long, it typically does take a while. So I think this turnaround time is pretty typical.
Representative Tulersky.
Sure, thank you. I just want to comment on that. because we were able to receive this draft I have in my House Bill 2 binder right here. We got this draft that was posted last Friday evening. And the fact that this information was available in a different format, that this could not be included somehow in that draft, I find that extremely difficult to comprehend. I'm really concerned about transparency here, and I know there's nothing we can do, and I know I've heard this is the way we've done it for years. I know that this section of RSA was amended July 1 of 2023, where I think we attempted again to clarify what was required. But I apologize for taking so much time. I expressing my frustration with this process and the fact that we are not prepared to have a deep dive into these extreme policy changes that are proposed. So I won't take any more time, and I thank you for letting me express that.
Okay, I would just add to that,
Just a quick comment. Just
Representative
for clarification
Nalvanko.
purposes, I don't think I have a copy. I don't think I have a copy of that 5-point. But having said that, the question is we're talking about federal policy changes we're talking about state policy changes.
Yep.
Okay.
There's a document that maybe was drafted and is what the governor wants to do. It's unclear. It is literally just type on a piece of white paper.
Okay. Are you all set, Representative?
Yeah, I think so.
Okay. Well, I just want to again clarify, my response to the House Bill 2 issue is not this is the way it's always been. It's just my response is this is how it is. So I just want to make that distinction very clear. The document in question, so the 5 points, which will be up on the website within the hour, which we will get to, I consider a working document. It has potential for amendments to House Bill 2, which we will have spend plenty of time on as a division. But that is, for all intensive purposes, a working document that we will look at today. Whether or not it's going to be in the final version or, the version that's going to be published, that I can't answer to. I can just only manage today's work session. Okay. Anything further from Division 3 members? All right, with that, we're about to tread now on, correct me if I'm wrong, but this is the largest accounting units in the entire state budget process, and that is Medicaid services, just to point out and highlight the enormity of our task and all that you do. Which reminds me, I want to thank all of you for all of the work you put into this. We all get caught up in details and figuring things out in the whole 9 yards as outsiders, but you have done so much work to prepare and to familiarize yourself and come back with answers and so forth. We are deeply grateful for the time you put into the preparation and presentation. So with that, I'll hand it over to the both of you on our work session, Medicaid services.
Excellent. Good afternoon. Nathan White, Chief Financial Officer with the Department of Health and Human Services, and I'm here today joined by...
I'm Henry Lippman, the state's Medicaid director.
So just to kick things off and address a little of the conversation that's transpired here this morning, we have before you a couple of different documents. The first is the PowerPoint presentation, and we will be going through the policy changes that are described in the document that was being discussed before. We've included some financial details on the specific impacts, as well as some of the federal regulations regarding those policy changes. So that will be discussed in detail today. I just want to make that clear. I would probably recommend using this as the document of record and maybe set aside that other PowerPoint or that other bullet document for the time being. In the governor's operating budget, we will begin on page 885. And we will be discussing the accounting units that run through page 893. Again, that's the governor's operating budget, 885 through 893. So while it is a large budget area of the department and the state, there's actually relatively a smaller number of accounting units because of the nature of the funding and how it's accounted for. And then finally, in the DHHS budget briefing book, the Medicaid begins on page 1 of that document. And just as a quick reminder, the only accounting units that are included in the budget briefing book are the accounting units that are over $1 million. And so with that brief update and orientation, I'm going to hand it over to Henry to start to go through the Medicaid program.
Thank you. If you turn to slide 2. So what we intend to cover this afternoon with you, and certainly we'll take questions as you would like to. We try to anticipate what you might like to learn about, but we're certainly open to hearing, to compare the agency and the governor budget. Just as a high level, in this budget, the difference between the agency budget and the governor's budget is about $60 million in reductions that are in the budget. As you know, or may not know, the Granite Advantage Healthcare Program is an off-budget item, and there are $10 million of reductions in that. And then we'll try to speak a little bit to some of the issues that are being discussed at a federal level that would impact this budget greatly, potentially. And then we have an appendix, some of which, if you attended our Medicaid 101, there's some of that material there, but we added some other materials that we think you might be interested in if the time allows. And certainly if you need more time with us, we'll make ourselves available. I'm now going to slide 4.
Mr. Lippman, we appear to all have a question already.
Okay.
So that would be Representative Priest for a question.
Thank you, Madam Chairman. Again, just as a clarification, so we're talking about a $70 million difference between the agency budget and the governor's budget.
Over the biennium, yes.
Okay, thank you.
Representative Daniels for a question.
Thank you. I thought you said that the Granite Advantage was off budget.
I stand corrected. That $70 million reduction in the budget,
Okay. thank
60
you.
of which is within what we're looking at in terms of,
And just as a follow-up, is there a reason why that's off budget as opposed to included when we're trying to look at the whole?
so the department's agnostic about where it is. It was a legislative decision.
Okay, thank you.
Representative Stringham for a question.
Yeah, is the comparison based on the efficiency budget or a budget with prioritized needs? And just quick follow-up to that as well. Go ahead.
Sure. Well, I guess the question is how would you like it compared? Because not to be difficult, but so in the operating budget, Chapter 106 for the current biennium, we have the budget, but then there were dollars included in the Medicaid rates that were included in HB2. So we can compare it, just from the governor's budget here in front of us. But if you'd like us to look at it a different way, we can certainly do that.
I guess the question, I was just trying to determine what framework you were using. There's probably value in looking at it many different ways. So,
Sure. So I would just need to confirm Representative Priest's number there. I just take 1 minute to validate that. But go ahead, continue.
So slide 4, page 4, the Division of Medicaid Services provides what I think you would all understand to be like the health insurance program that people have in Medicaid. There are other parts of the department where my division helps with the financing of other areas, like, for example, in long-term services and supports, which is a budget you hear later. This pictogram on the right-hand side here is just to sort of say that Medicaid has a division, but we're also play a financing role in terms of we're as the Medicaid agency, where the sort of the direct connection to the federal government for Medicaid, and they look to our division with respect to the compliance of the program and what have you. Also on this page, on the bottom right paragraph, I would note that in New Hampshire, about 1 in 7 individuals are enrolled in the Medicaid program. That compares nationally to 1 in 5. Slide 5, New Hampshire, sorry, see it.
Yeah, Madam Chair, I have a quick question.
Sure,
So the-
Representative Novanko for a question.
Yeah, thank you, Mr. Lippman. So the 1 in 7 is based on the expanded Medicaid coverage, or?
The entirety of the Medicaid program, that enrollment against the state population.
Okay,
And the 1 in 5 is against the US population nationally.
okay, thank you.
Representative Telersky for a question.
So a quick follow-up, that's that 180,000 or 189,000 that we talk about?
Yes.
Thank you.
And just another, on moving to slide 5, we are the 4th smallest Medicaid program in the country in terms of, as measured by enrollment. We, in addition to the medical program, we offer dental care, which is, hard to disconnect from the medical. The mouth is part of the body, and we, the legislature approved an adult program, and that started in April of 23. Children for dental are up to age 21. You're considered a child for purposes of dental care, and that's through a fee-for-service as opposed to a managed care model. As I mentioned, the second bullet, where the interface with the federal government Centers for Medicaid and Medicare Services, and we work with all the divisions in one way or the other in terms of helping where there is federal funds available for support of services and where Medicaid coverage can come in. And I'll point some more of those out as we go along. Basically we're leveraging the general funds and other funds that are available in the state to deliver services to many individuals, and includes also children in school who are have IEP and 504 plans. We mentioned at the bottom there, and I'll cover more of this as we go through, some programming that has come through our 1115 waiver, an adult community reentry. What that is for the first time federally, the prohibition about inmate exclusion, that they're allowing states to be able to draw federal funds to help with the transitions of people leaving the correction setting. As you may or may not know, that in New Hampshire, the number one reason for people to have recidivism back to prison or jail is that oftentimes mental health and substance use disorder being untreated. And so what this program tries to do is get people connected to those services before they leave and to provide medications so there's less of a risk. It's a very limited program, but it's designed to help with healthcare ultimately for the Medicaid program, but will also be helpful to the correction system in our state in terms of the number of people that have recidivism. And then briefly on page 6, talk about some of our few key accomplishments, and I won't belabor this today, but on youth reentry is a federal requirement of all states that began in January. It's somewhat similar to what I described as the adult community reentry. It's a little bit more tailored program. In the correction system, there are people who would be considered adults in that system, but in Medicaid, they're still considered a child. In fact, former foster care are entitled to youth benefits until they turn 26. And so what this program tries to do is make sure that those services that define what a child's needs are identified before they leave, that there's transitions set in place so that when they come out, hopefully if they're eligible for Medicaid, that's already established, and that they have extra case management provided. One of the questions that we fielded was about the Medicaid unwind during the continuous coverage, which went from March of 2020 to the end of March of 2023. States had the first opportunity to unwind from the continuous coverage. Federal government asked states to take at least 9 months, and in many instances they needed more. We were substantially completed in 9 months for the most vulnerable population, like home and community-based and nursing homes. We took the longest it's a relatively smaller population, but we were accomplished pretty much from April 1st to the end of the calendar year. We were largely complete, and we had to catch up on over 200, in this case, 238,000 roughly redeterminations that weren't done during the public health emergency because people didn't have to. What I would give the state credit for is we tried to work with people, because you may or may not remember that at one point during the federal public health emergency, it was being renewed every 90 days. And so we didn't want people to lose coverage because we didn't have the capacity to respond to them. So we tried to work some of that down in advance with individuals. And so we got about 30,000 redeterminations done ahead of time, which gave us a little bit more bandwidth to be responsive to our citizens and to the people in the program. When we saw closures,
Representative Telersky for a question.
The fact that we're talking about the unwind is why I just want to stop briefly. The document, the bullet document, section 1, when I read it, which talks about return to regular eligibility redetermination, when I first read it, I sort of thought to myself, well, we've already done this. Can you please explain to me what section 1 on the document means and what this will translate to in policy changes?
Sure. During the end of the public health emergency and the beginning of the unwind, there were federal authorities that states could use, because trying to catch up on 238,000 redeterminations, wasn't just a problem for New Hampshire, it was a problem for the whole country. They gave us different flexibilities, like we gave people a bit more time, because some people who came on the program had never done a redetermination before. For older people, it takes time to, get documents and things. And we were able to use different authorities to ease the burden, if you will, of getting back into the routine. For some people, it was 4 years since they had to go through a redetermination. And so those authorities are available to us until June of this year. And so what the statistic that's on slide 4 there is what we're anticipating based on what we've seen. And despite, I think, efforts that far exceed what many states did in terms of trying to get people to complete their work, and we went well above and beyond what was required, there are a number of people who still don't do that work. And if they don't do that work for redetermination, at some point we have to close them. And that is factored into that number 1 on the piece of paper that Chair Mooney and you had brought to our attention. So that's, I guess, what we modeled as being the financial impact of returning to regular pre-pandemic guidelines for processing redeterminations.
Okay, so do you have an estimate of how many people are going to be affected with this continued redetermination of eligibility?
I do have that number. I don't have it off the top of my head. Okay, thanks. So that's Deputy Director for the Medicaid program, David Chorney. So in terms of one of the things that we did during the federal public health emergency is look to increase the level of ex parte renewals, meaning those that could be renewed based on, if we already have the information through our sources, we don't ask the person to provide information that we already have. So the part of the flexibility is around what we could use for information. That's going to scale back. So we're anticipating this to be, the ex parte rate will come down about 2,000 individuals a month, and we're expecting about half of those individuals. Our experience has been about 51% won't stay open. Now, the thing to point out about Medicaid is that it's unlike private insurance where there are open enrollment periods. Medicaid's continuously open. So if someone does close and they do feel that they need it, they can reapply, and there's no waiting period.
Okay, thank you.
Mr. White, you wanted to add to that?
Sure. From a budgetary perspective, in state fiscal year 26, we would anticipate this change would be about $5.7 million of general funds and equivalent amount of federal. And then in the budget, it's also in state fiscal year 27 at approximately $11.4 million of general funds and the same amount of federal dollars for the second year.
Okay, sure.
Okay, Representative Stringham for a question, then I think that wraps up this
I think
round of questions.
I think I pretty much understand. So you're saying you basically have of the 8,000 or so that if you're looking at over the next 4 months of doing, or is it 2,000 a month going to continue into the next biennium? You're still going to be working people off and doing redeterminations that your initial budget did not include.
It's required to be done annually, and so we're expecting that there'll be a certain amount of churn. Some people come back, but then some people won't.
Isn't that business as usual for the Medicaid program?
Yes, and that's why we call it return to regular operations, if you will.
Representative Priest for a question.
Thank you, Madam Chairman. Again, for clarification, the 5.7 million that you are estimating for 2026, is that cost savings? And 11 for 2027?
Yes. So that reduction that you just referred to, that's reflected in the governor's operating budget that you were looking at before you.
And again, that's because you anticipate a number of people will be redetermined and will be taken off of Medicaid.
Actually, it's that they won't, that after noticing and the time allowed, that they choose
Okay,
or
great.
aren't able to do it.
Okay, thank you.
If I could add one more comment, one of the things that came out of the federal public health emergency experience for us in the continuous enrollment is all during the federal public health emergency and the continuous enrollment, we actually reached out to individuals to see if they really wanted to stay on Medicaid. And surprisingly, there's, sometimes if you don't ask that they need it anymore, they don't do anything about it. So we found in the last 12 months, there were 11,000 individuals who closed based on outreach. Now, we also reach out to people who close to make sure that if they need help to redetermine, to help them get through the process. But there are individuals, and we'll get into this a little bit more later on, but I'll just throw out this statistic today because I think it'll give you a little bit of feel. Like in the Granted Advantage program, the average tenure on the program is less than a year. And there are 87,000 people approximately in the last year that were on the program. Today's enrollment is just around 60,000. So there is a level of people coming on, having their needs met, or by either leaving the program Medicaid entirety or that they may be disabled or something and they're going to a different level of Medicaid. And so I think that, we're trying to be responsible to make sure that people who are eligible and want to get there, that we're doing, I think, extensive outreach, much more than was ever done. And those people that are letting us know that, hey, I've got other insurance now, I don't really need it, you can close me. In fact, just anecdotally, there was a period of time in the pandemic where CMS had made a rule change and the courts said you can't do it that way, and we had to reopen people. Had some, anecdotally, a few complaints from people saying, I still didn't want Medicaid, why did you reopen me? And so, we do, I'm not saying that's the majority in any way, but I'm just saying that there is an element of individuals who their needs change and they no longer need it. And there still is, particularly with children, we still today call every family. We have the MCOs make calls and we make calls to find out kind of where they're at. It isn't all about closing people. It's about making sure those that are eligible, if we can reach them, and they need help in completing it, that we support them.
Representative Priest.
Thank you, Madam Chairman. Out of the people that apply for Granite State Advantage, how many are rejected because they just don't meet the criteria?
The criteria for Granite Advantage is it just an income only criteria?
Right, okay.
I don't have that stat with me. I don't know if my team does or not, but we could get that statistic for you.
And that 11,000 that you talked about people closing,
Yes.
was that just a particular month, or was it
No, that's for entire 12-month period.
for 2024?
Would be from, actually, the period that we measured that I'm speaking to is from February 1st of last year to through January 31st of this year.
Okay, thank you very much.
The last bullet on that page was, we re-procured the entire Medicaid managed care program for another 5 years. And we appreciate that the legislature reauthorized for 7 years, which helped, I think, us get a better contract. And we, used our experience over the number of years to make refinements in the program. And I know today we're trying to focus on budget, so I'm going to maybe come back to more of that later if there's time. On slide 7, just provided some information that allows you to compare in different eligibility groups how New Hampshire compares to the United States on average. And, you can see the 1 in 7 and 1 in 5 repeated again at the top there. On slide 8,
Oh, we do have a question, Mr. Lippman, couple questions. Representative Daniels, followed by Representative Wallner.
Thank you. Is there a difference between being on Medicaid and being in the Granite Advantage program?
they're both Medicaid programs. It's really the federal match. The benefits are exactly the same. An adult in Medicaid who's not on a waiver gets the same benefit as someone on Granite Advantage.
Okay, I'm just trying to reconcile your comment that there were 50,000, currently about 50,000 in the Granite Advantage, but yet on page 7, you're talking about 185,000.
That's the entire Medicaid population, not just Granite Advantage.
Okay, thank you.
Representative Wallner.
Thank you. When you did the rewind and you started having people leave the program, do you have numbers as to how many children went off, how many people in nursing homes went off, how many people
Yes.
on Granted Advantage? So would those be available to us?
In fact, later on in the presentation, I think we'll come across a
Great.
table that has that information.
Thank you.
Proceed, Mr. Lippman.
Thank you. I'm on slide 8, and I'm not going to spend time on this, but I thought for interest, based on the fact that the House of Representatives represents typically county boundaries largely, but not. It's just so you can see in terms of the standard Medicaid program and Granted Advantage, and in total, what the enrollment is in your communities that you serve. And let me make this point too while I'm right here, is that when we run numbers about enrollment, there are different ways you might see the numbers vary a bit. We do enrollment all during the month, so sometimes we're reporting on the last day of the month. Sometimes we're reporting on who was covered during the month. Like when I said, Granted Advantage, there are people who come off and on all the time. So some data runs we're running, through the month, and some are just end of the month points.
Representative Telersky for a
Thank-
question.
Thank you very much. Looking at this map, or looking at slide 8 there, the middle map,
Yes.
I'm seeing that 60,505 persons. So I'm assuming this is the Medicaid expansion granted advantage.
Yes.
So this is another topic that I'm sure we are going to talk a lot about. But with New Hampshire having a trigger law, that if there's any drop of federal funds below 90%, our program of granted advantage will expire. So would I be correct in seeing this, that 7.2% of the New Hampshire population would lose their Medicaid coverage?
I think that's what that statistic represents, yes.
Thank you for that.
Let me do a double check in my math on my head on that one. No, I think that's 60%. Run the math on that for me. Of the 7.2%. Yeah, no, it's not of the entire population, right? It's because 187 would be about one in. Yeah. I'm not correct on that number, so let me have someone run the calculation. But
Sure.
it is if 185 is approximately one in seven, right? So it would be 1/3 of the 1 in 7 would be the kind of math of that.
Well, as you can imagine, I'm extremely concerned
Yes.
about the potential impact to Granite Staters. So I'm sure we will dig into those numbers and your team can figure out the impact of that. Thanks.
And I will have a comment that sort of addresses that very shortly in the slide deck. Again, a couple of facts here in terms of the top left-hand side of slide 9. New Hampshire, 22% of our births are under Medicaid. Nationally, that's 42%. In terms of the bottom left-hand side, the chart, we cover 15% of the women in New Hampshire who are in the 15 to 49 versus 21% U.S. And the chart on the right just is, I think, with the Granted Advantage program and such, our uninsured rate, it's not the lowest in the region, but is lower than many others. And on slide 10, get to the point I think that you were trying to raise a moment ago, Representative, that the way New Hampshire is structured right now in terms of its insurance market, we have, of course, the Medicaid program. The Granted Advantage part in particular, if that were to close, if you kind of think about risk pools, you've got the private insurance through employer-sponsored insurance. You have the ACA coverage that's available to people, and then you have the Medicaid program. And you may remember at one point when we started Granted Advantage, we began it in the ACA marketplace effectively by buying private insurance. And while our first year or two of experience was not bad, it actually saw it push up rates in the individual market. And so what my point here on the right-hand side is, even if you don't have Medicaid, you should have an interest in the issue of coverage, because while we've achieved something as a state in terms of with, I think, having granted advantage and the 1332 waiver in terms of bringing our rates of coverage outside of Medicaid down, if this population is no longer covered in the Medicaid program, it probably will have, I think, a negative effect on everybody who's buying insurance on the individual market or on ACA coverage. And so I think that there's a reason to care about Medicaid, even if you're not on Medicaid, because I think it has a positive effect on the overall market. And you can see with the 1332 waiver and granted advantage on the left-hand side that New Hampshire's premiums have come down. And today, while they're still very expensive, our ACA coverage is either the lowest or second lowest consistently now.
On the topic of waivers, Mr. Lippman, is there a way to find a list of waivers, or is that available?
Yes, and I'm not sure if we have in the slide deck our waiver wheel, but if not, we can get that information readily to you.
Perfect. Representative Stringham for a question.
So you indicated that eligibility and enrollment in Medicaid has a positive effect on reducing premiums for managed care and commercial plans and those types of things that are often paid for by New Hampshire employers. Did I understand that correctly?
What I was saying is the granted advantage population is more expensive in the commercial market than it would push up the rates based on their use rates, if you will, compared to it not being there. And if you may recall, the insurance department actually did a study on what the impact was of moving from where it was back into the Medicaid program, that there were savings in the commercial market for that.
So as a follow-up, would you be concerned that a policy change on the Medicaid program or the Granted Advantage program may reduce the enrollment rate in the Medicaid program, and then have kind of the reverse boomerang back to the managed care plans?
I believe that is a possibility. I can't say with certainty because I'm not an economist, but that's my assessment of what would happen based on what happened initially, which is rates went up when we pulled the Granted Advantage population back into the Medicaid program. And with the 1332 waiver in the insurance department, our rates got a lot better as a state.
Representative Priest for a question.
Thank you, Madam Chairman. Back on page 8, when you compare the various programs in New Hampshire, on the standard Medicaid program, what percentage or what number of that 127,000 are children below the age of 18?
Below 18, I may not remember off the top of my head, but I think what we define as a child in Medicaid is just around 90,000.
90,000 of that 127?
Yeah, it may be 88 something, but it's close to 90,000 when
Okay.
you consider all the different children's eligibility groups.
Thank you.
Slide 11, if we could, is just the organizational chart for the Medicaid program, sort of key leaders in their tenure. The Division of Medicaid is maybe smaller than you might expect. It's 33 individuals support this division. If you turn to page 12, if we looked at this 2 years ago, our vacancy, which is the second column of this chart, we had a vacancy rate approaching, I think, about a third. We've been fortunate to be able to bring that down, again, thanks in part to the work the legislature did in terms of making wages better, but also I think that we've done a lot of good things in terms of improving policies in Medicaid that make it a more interesting place for people who want to contribute to that activity as a place to work. So we're grateful for what has been done. In terms of our vacancies, today we have 3. We have, in the budget process, we had 3 positions that were unfunded and 2 that were, I'm not sure what the right term is, eliminated, that were during the review of how people would be compensated. Some people went from classified position to unclassified. The classified positions were abolished, and they were clinical people, where that's where there were a lot of wage pressures, and so that's kind of, I think, what's happened there. I'm not sure if there anything else you would add there to what I just described.
No.
So now getting into starting on slide 14, we're going to sort of work through the budget briefing book as Nathan had relayed earlier. I think we've tried to, in red, put a couple of key takeaways. But as we go through this, I'm going to try to give you some concepts about what's going on in a particular area and then get into the numbers. So in 1371 is the maternal opioid misuse model. This was a Centers for Medicaid Medicare Service demonstration model that runs through December of this year. Was originally intended to be a 5-year model. It was allowed to go on for 6 years because of the pandemic. It was a pilot project in the greater Manchester area to try to help moms and children when there was opioid involvement to have the successful pregnancy and successful aspect with their children. We're not asking for any funds in this one, so this I think is a fairly straightforward area.
Representative Wallner for question.
Just a really simple question. How many mothers and children were involved in this program?
Obviously there's turnover. I think today we're running about 137 mothers in the program.
Thank you.
Representative Priest for a question.
Yes, and how many mothers are there now that are out there that are needing a program like this, and we have no program?
Well, the program is continuing to December. We're working on, part of these demonstrations are there to learn and to then to look at how you would change other things that we're doing, and certainly within the policies that have been approved by the legislature. For example, when we got this grant, there was not 12 months of continuous coverage, postpartum coverage. There was not, you've approved doulas, you've approved lactation services, donor breast milk. There's continuous coverage for children. So there are a lot of things that have come into play during this demonstration. We're also, working on thinking through how we can take that demonstration experience and I don't have the answer today of how we're going to utilize it completely, but we're trying to learn from the model to figure out how we can, with funding that is no longer coming from the federal government, to continue to advance progress for women and their children.
Thank you.
The next section, still on page 14, but in the budget book, is 886.
The governor's operating.
Yep, the governor's operating budget. And here we're talking about a grant that New Hampshire applied for. Medicaid to Schools is a program that I think sometimes gets conflated with other concerns that, out there about what happens in schools. But Medicaid to Schools is really a targeted program to help children who have either medical or disability conditions or both to be able to accomplish their learning in school. And so, for example, a child that might need insulin shots or medication during the day that, or they might need physical therapy or a rehab assistance to be able to do learning, that there's a way for the state to obtain matching funds that actually 100% go to the school districts. So New Hampshire has had a claiming methodology, which has been long-standing, that is being phased out by the federal government. By July 1 of 26, we have to be on a new claiming methodology. So we sought this grant. It's a 3-year grant. This represents the first period is in the budget, but ultimately we hope to be able to draw $2.7 million at the max to be able to support school districts in transitioning to a cost-based methodology. And the advantage of that for the school districts is, for those of you who are familiar with what happens at the county level, the county nursing homes are able to get additional reimbursement to fill in part of the gap between what Medicaid pays and the cost of the nursing home, that those uncovered costs that are less than what Medicare would otherwise pay, that we make a payment to sort of fill part of that gap. Similar schools can do something similar to that, where instead of getting the contribution that the school is making towards the cost, which is 50%, we have historically administered that as half the fee schedule represents half the real cost. And I suspect in many instances it's well below their real costs. And so this will put them on a platform where they'll be able to claim half the costs. And that will, I think, provide more funding and help school districts and property taxpayers with the cost of financing these services in the school environment. I also do think that it's worthy of some exploration in terms of the issue of, skip me. The term I'm looking for, special education, was the term I was looking for, is where, if you look at, and we'll look at later on, some of the trends in using this program have gone down quite a bit. And, you know, are there opportunities to work better with the school districts in getting Medicaid participation instead of having to be 100% general funds or what have you? I'm not representing what that might be, but that I do think that's worth exploring further. And basically, this is to fund the technical support that we need to implement that program in 174 different local education administrative units in the state.
Representative Priest for a question.
Yes, back on the Medicaid to Schools grant, how many children are we supporting now with the program? And you said it's a 3-year program starting this year, so it will end in 2028?
The Medicaid schools program is longstanding and will continue to stand beyond the,
Okay.
what we're doing is getting our claiming methodology from the federal government in line with what it needs to be to continue to claim federal dollars.
I see, okay.
And the big thing that the federal government wants is they want to know what costs are. And we've had to switch claiming methodologies in a number of different areas in the state in terms of the Glencliff Home, New Hampshire Hospital. We've in reforming the DD population payment system, we've gone to a cost-based system. I think as legislators, knowing what the cost of the services are, and as the federal government, it's in terms of looking at the adequacy of funding, if you know what the true cost, I think that's I think where the federal government's going with this.
But how many children are we providing services for? do
So
you
I
know?
think in our last report, it was just under 9,000 children had benefited from it, and it has been a higher number in the past. I think at its peak, we probably were closer to 14 or 15,000. Medicaid's not an easy thing to master, and I think hopefully through this grant, we'll be able to help bring up the capabilities in the state so that those dollars that the state's entitled to in the school setting for those services that support learning, that we'll be able to access them.
And I think I see that number 9,000 on page 16 of the handout. Is that the number you're referring to at the top there?
Yes.
Okay.
Yeah,
Okay,
nine-
Representative Nelvanko for a question.
Yes, thank you, Madam Chair. So the change in claiming methodology, so do you anticipate that that's a net plus, minus, or no change? Just attributable to methodology change, is that, likely to increase, decrease costs, or
So-
what's the net impact of
The
that?
net impact is favorable to the schools in terms of being able to get a higher level of match because I think their true costs are higher than what is recognized in our rates. So for example, if you're trying to pay for a physical therapist who's in the school setting, you might have to contract with them at $100 an hour or $100 per certain element. And we may not be paying enough to pay someone at $100 per hour rate. And so it will help close that gap.
Thank you.
Okay, Mr. Lippman, we are at the 1 hour point. I want to make sure that everybody's comfortable here. It's a very intense topic. If you need a break or anything along that line, we are on page, 16 or so of 70. So you lead the way, Mr. Lippman, but I want to make sure you're completely
Sure.
at ease here.
Thank you. I'm fine.
Okay.
If you
And-
are,
And the way the flow of the questions are going, that's okay with you?
yes.
Real good. And I appreciate the members being patient. I don't have the benefit of a vice chair to tell me when a question is waiting. So I appreciate everyone just being patient while I look around to see if there are questions. Thank you. You may proceed.
So page 15 and page is it 887 of the governor's budget is the adult dental program. And what you're seeing here in this page is the adult dental program from the standard program. There's also the adult dental program goes into Granite Advantage. The dollars to cover the adult dental program today from 2023 through, we anticipate through this whole biennium, the state had a settlement with one of the MCO companies that is providing 100% of the state share, for that time period. So the dollars that are represented here are those coming from that settlement and a federal match. If you'll notice, it's also gone down. When we first scoped out the program, we didn't know how many dentists would actually enroll in the program. We've grown up to over 190 dentists in the program. We've also used mobile dental services, fully equipped dental operating environments, which include a dentist and staff that we actually even many weekends we're providing dental access on Saturday and Sunday at different locations throughout the state where we have a shortage of dental providers. But what's reflected here is an expectation of where we think we are based on actual experience. Delta Dental's been an excellent partner in terms of working with us and trying to grow the dental network, and we're hoping over time that we'll continue to see growth and be able to serve people. But what's in here is what we reasonably expect based on where we are today.
Representative Stringham for a question.
So according to the budget, the actual expenditures in 2024 were about 11.5 million, and you're projecting 7.2 million now. And it would seem like there would have been more providers online. Was there just huge pent-up demand, or what? Is there any explanation for 30-40% decrease in services?
Sure. So I'm not. I think I need to go back and look at why it's showing up as actual expense that year. But when I'm looking at today's expenditures year to date, we've seen about $2.2 million of expenditures year to date in this state fiscal year, which is much more consistent with the amounts that we've budgeted in subsequent years.
Is that
If I
Is
could,
that all funds or just general funds?
That's total. Well, there are no general funds in this accounting unit. It's just federal and the other funds from the Centene settlement.
so one of the things we did, which I think was an excellent business practice, is, and if you followed the news in some other states, we actually put a minimum medical loss ratio or dental loss ratio to make sure that if they didn't spend a certain amount of money, that anything below below that ratio would come back to the state. So I think what's not reflected in there yet in the actual experience is that we are going to get a refund on that.
Representative Telersky for a question.
Thanks. I just sort of have an anecdotal perspective of the adult dental program when I see constituents comment on like a local Facebook page saying, I can't find a provider that takes the program. Now, there's obviously a very large demand. I do know the program has been successful where it can actually be utilized. Do you have any idea of what we actually need in terms of number of providers to provide the service that's actually needed?
I can give you an answer, but I'd
Yeah.
rather consult with dental director to give you a more precise answer. But I do think that we are seeing an increasing number of individuals, and if someone is having a problem that you know of as a constituent, please call me.
Thank you.
And we'll, we have actually, when we do the mobile sites, we have lists of people who we can call last minute, like you see dental office sometimes do that, where, they're on standby if someone else doesn't show up, that we can fill that space. So, I think we're doing all we can to extend it, and I think it's going to be with time that other dentists will hopefully join the program. I think New Hampshire's fortunate. We now have the president of the ADA for the country is now a dentist from New Hampshire. So I'm hoping that we can continue to build a network. I think that we'd like to have seen it even better, but I'd say based on what we've done, it's gone pretty well. There's still room to grow and improve.
Great. Thank you for that.
Representative Nelvanko, followed by Representative Stringham.
Just a quick question. So this is preventative care as well as, I'll call emergency care or.
We can provide you with what the coverage is, but it includes preventative care, it includes fillings, it does not include gum surgery per se, but what you would typically find in a commercial dental benefit, you would see in this program. But we actually, in the legislation, there's specific that adopted the program. There's some exclusion of certain services, but for example, the people in waiver, people in nursing home have access to dentures as part of this program. So, one of the things that can cause a person to deteriorate is not being able to eat right. And so, again, with the leadership from the legislature, there was a willingness to add dentures for certain populations. Other populations were excluded.
Just very quick. So that's the preventative care would be, I think, typically two checkups a year.
Yep, cleanings and so forth. I think it's a program that many people work hard on for many, many years, decades even, to bring about. And I think we're fortunate what we're able to deliver here. The next,
Representative Stringham.
Just if you could share, not today, but if you have anything about the rates and whether there's been any feedback from providers who have signed up of whether the rates are adequate for them, to take the Medicaid patients over others that may come to their doors. I'd appreciate it.
we can do that. If I could comment, though, that when you did the rate increases in HB 2 of 2023, we were able to make our children's and adult dental rates, I think, probably, very competitive what other Medicaid programs are able to pay. I think we're probably somewhere around 72% on average of the commercial market in terms of the rate for dental services today.
And just on the, all set, just on the topic of the Centene settlement, it would appear that that is a pilot program. Is that fair to say?
Well, I think I don't think it would be fair to call it a pilot. It's the funding that I think that was available to get this program over the finish line, if you will, legislatively. It remains to be seen once that's run out whether, it will continue, but we're hoping it does.
Well, that leads to my next question. It would seem in this circumstance that data is needed for future budgets, and anything you could provide related to that would be helpful.
Sure. So at this point in time, at the end of the biennium, we're projecting about a $960,000 balance of the Centene funds. So we anticipate having sufficient other funds to support the program through this biennium. But beginning in the next biennium, we will need to address that question of how will this program be funded going forward.
Thank you. And that's where I think the data will be very helpful in terms of future budgeting for the continuation of said program.
We do make regular reports to Health and Human Service Oversight that we can share that with this committee as well in terms of that type of information.
Perfect. Thank you. Representative Priest for a question.
Thank you, Madam Chairman. Again, that number of unused funds going to be applied for this?
So we're projecting for the end of state fiscal year 25 about $11.5 million, and then at the end of the subsequent biennium about $950,000.
900.
But again, that'll depend on utilization.
Okay, thank you.
Go ahead, Mr. Lippman.
Thank you. Bottom of page 15 is the Children's Health Insurance Program, which, oops, of course, my computer is on your, my computer's not responding. That begins on page 900 towards the bottom, goes on to 901. If you're a member of fiscal committee, you may have heard this morning that we had a transfer into this account that we made. We began separately accounting for the Children's Health Insurance Program, where we get the enhanced federal match separately. The time we made the original projections and starting to do this, we had a few things that came up that weren't anticipated, like the federal public health emergency and continuous enrollment. We also had the federal requirement to cover children for 12 months continuously. So I think based on going into this budget, we have a better sense of the experience. And we're also reflective in here, I think, is a point where number 2 comes into play. That was on the sheet earlier in terms of the ultimate costs that will be incurred here. You want to address that?
And just for clarification here, we are on page 890 of the governor's budget at this point.
900 and 901 is what I have.
I
No.
have 888.
Yeah, so the Children's Health Insurance Program accounting unit is 7051. It begins on page 887, and then it continues on to 888.
Right. Sorry, I gave you the PDF numbers.
It's okay.
Okay. Proceed.
So I think what we're seeing here in part is what's factored into the governor's budget is revenue from premiums. We are going to make a budget adjustment in terms of how it's in a budget adjustment request. What we feel is the revenue that's brought in from premiums should be shown as a revenue as opposed to netting it into the expenses, but the effect is ultimately the same. What we're anticipating in revenue, which is effectively expense reduction, is about 3.3 million in the first year and about 11 million in the second year. And the reason there's a difference between the 2 years, it'll take a little time to implement, and then we have to phase it in based on where people are on their coverage and their 12-month continuous coverage. And the eligibility level that's in here is, so we go up to 323% of the federal poverty limit. That's not changed in this. What is changed is that whereas we have no premiums today, only cost sharing on pharmacy, that there would be premiums starting at 255% of the poverty limit, that not being the child, but the family income. And premiums by federal law are capped at 5% of family income. And so what our intention is also from the standpoint, if this is the policy that ultimately is enacted, is to, since the maximum someone could be, we have to keep track of what they've incurred in claims. If someone's paying premiums, we won't have other cost sharing, because otherwise we'd have to make an investment in our IT structure that we can avoid by keeping it simple. And that's what we're talking about here. In terms of other states that, nearby, Massachusetts and New York are two states that are have premiums, but you go across the country, there are about 18 states currently that have premiums with children. At one point, it was, I think, as high as 26. New Hampshire did have premiums back when children's health insurance was provided to through the Healthy Kids Corporation, and at that time, the premium started at 186% of poverty, and also that there was both cost sharing and premiums. I think we're trying to keep it simpler and less costly to implement if that's what ends up being enacted. And let me stop there because I see there are people who I think want to.
Representative Wallner, followed by Representative Tulersky, but it looks like Mr. White just wants to interject here. Would you yield, Representative Wallner?
Sure. I just want to add a point of clarity. So in the governor's recommended budget, there was a reduction of $3.3 million in state fiscal year 26 of general funds, and a reduction of $11 million of general funds in state fiscal year 2027. If it's the committee's desire to keep this policy, we would recommend a change request. It's a technical change request to increase the other revenue by the equivalent amounts as well as the expenditures. There was just a technical issue in the reduction where we reduced both the general funds and the expenditures, but we didn't increase the other revenue to recognize that. So I can provide the change request if the committee chooses to take this direction.
Representative Wallner.
Thank you. Could you go into a little bit more detail about how this premium would be collected? I actually served on the board of directors of Healthy Kids. I was the legislative appointment to that. And I remember the board struggling in the situation of the collection of the premium, and families that didn't have it. We tried to do fundraising to help subsidize families that couldn't come up with a premium. So could you kind of talk through what happens when a family doesn't pay the premium, or the check bounces, or, and how will they be able to come back on at some point? What's going to happen here?
So your last question is the easiest one to answer, which is, as I mentioned earlier, that Medicaid's continuously open. So if someone does close, they can apply again. In terms of the method of collecting the premiums, we have some thoughts about that in terms of how we would sort of set that up. What I'm trying to do in approaching that is come up with a simple solution, so the cost of implementing it doesn't consume all of the potential revenue. There are ways that I think potentially exploring some systems that the state already has, or a vendor where you would work for a percentage of what you collected to provide a infrastructure to be able to make payments or ACHs from a checking account. I mean, the issue of people who don't pay is a policy development area that we need to work on. We haven't we haven't gotten that far to be, transparent about that, but we know that we're going to have to develop policies around what happens if someone doesn't pay. And, what I can say is that, we'll have to look at what is allowable in terms of the federal law on those types of things. And we have factored into our estimate of dollars that it isn't necessarily going to be 100% collectible.
Representative Wallner.
So how many families fall above that? What was it, 255%?
I believe that we're estimating 10%. Correct on that. Which is about 8,600.
8,600
families.
children,
Families. where-
families, it might be more children.
Yeah, it's, we're
It's
figuring about
8,600.
10% of the children that are in the program that
Might
would
be
apply
less.
to.
This is just a question I have about all of this. When
86,000 children.
someone can't pay the premium or they let it lapse or whatever happens, and they are in the midst of some medical, really serious medical issue, cancer or some other, kind of thing. What happens at that point? They just, they lose it and then they have to go.
So I think we have some policy design choices about that. We encounter that today sometimes where someone may be so destitute that they can't get their medication. And so we do have some policies, and that's what I was saying. I think, this is fairly new to us as well in the department in terms of, developing the strategy, but, I think we'll be transparent about what it's going to look like. I do think we have to take into consideration people under active treatment and that you can't just drop them. So I think that's part of when we were doing our estimation, we didn't assume that 100% of the premium potentially could be collected. So I'd rather not, speculate on what that's going to be until we develop the policies.
And just one last question. 5% of a family income at the level of 255% of poverty is really substantial. I tried last night to do some math, and I mean it's a family's car payment, it's their a portion of their rent, it's their childcare expense. Do you see any other mechanisms for helping these families pay these premiums? I think that we're gonna see a number of families that are just not going to be able to do it.
Again, I think there are a lot of issues to work through to implement this, and you're identifying a number of them today. I don't have all the answers today to be, totally transparent.
Thank you.
Representative Talarsky, followed by Representative Stringham, followed by Representative Nalvanko.
Thank you. Thank you very much for taking my question. Well, to follow up on what Representative Wallner was getting at, I did dig into some math a little bit on this. And I used a hypothetical single mom with 2 kids who is at 255% of the poverty level, which means she makes $67,958. 5% of that is $3,397.90 a year and $283.15 a month. So just, although we don't have answers on how it's going to work, let's assume that she has to pay a premium of $283.15 a month. Am I correct so far? I know you can't answer. I'm going to assume that that's accurate up to this point. So is it true, though, as Representative Wallner stated, that that's for many families a car payment, which would get her to work to be able to pay for this in the first place, that if she got dropped for whatever reason, due to something, catastrophic injury, whatever, she just didn't have that money to pay her $283 a month. Isn't it true that with an increase of care, uncompensated care, because she, let's say, is going to still need that emergency care treatment, she has to bring her child who broke his arm to the ER, and that child is no longer covered, that in the end, that raises the cost for the state significantly, and that this $11 million a year that we are, quote, saving is actually going to be significantly more?
I guess in terms of the scenario that you talked about, there was a piece of it I just want to clarify. I thought I heard, and I may not have heard correctly, that where her income changed at some point. Were you making that?
No.
I misheard then.
No, she couldn't afford to pay the cost share of whatever the 5%, if it's weekly, monthly. And so she got dropped, which we don't know what that actually means, what it looks like.
So I think, the number I had in my head in terms of was at a one person, which is, your 283 calculation, I can run the number for you.
Well, we're talking about chips, so I did a mom with kids.
Yeah. Yep. No, I know. I'm just saying
Okay.
in my head, the number I had, I'm just having some
Sorry.
for the scenario you gave. I do think that, in many, I would say this about the state budget. In many instances, there are times when the state may or may not cover something, and that it's picked up in either by the federal government or by the local government or by the individual. And I think what this policy does is asking individuals of a certain income to share in the cost of it. And I think, in terms of our estimate that's within the governor's budget, it does not assume that 100% of that is going to be paid. There are going to be circumstances like you arise there where we're going to have to develop policies to accommodate certain situations, but some costs will be passed on to other areas. I think that's a fair statement to make potentially. How much of that I can't represent today until we have some experience.
Thank you.
Representative Stringham, followed by Representative Nelvenko.
Well, I guess we all use different numbers because I had a family of 4, but it came out to $350 a month. But the question I just had, I guess there are mechanisms for handling patients without health insurance. And we have facilities that are required as part of their charter hospitals and federally qualified centers that they take patients in need regardless of their financial ability. And somehow they have to get money that they never are able to collect. Somehow they get paid, and I think part of that is through uncompensated care fund. So I would just ask, I think the savings that we would have from collecting is going to be partially offset by those that don't get into the program and then become consumers in the uncompensated care fund. So I know you said you're not an economic modeler, but I just wonder to what degree, those secondary effects of this policy change have been thought through and reduced to numbers. And if not today, then I'm happy to, if you have anything, you can share it after this hearing.
Well, I think certainly we can talk to additional states about what their experience has been. I can say that there are many states that have continued to have, this premium cost sharing. I think that, other structures for dealing with reducing the budget, for example, you could put it all in co-pays, but then you have a problem with collections at the provider level, which could create access barriers. So I think, to the extent that the budget requires us to have participation of individuals, that there is some aspects of this that are going to play out in certain ways, and I guess we'll do some more work on that.
Thank you.
Yeah, I'm going to jump from the micro back to, the macro. So, and correct me if I'm wrong on this, but the demographics in New Hampshire, we've seen it's an aging population. And if I'm correct, I think the birth rate is dropping, at least nationally. Is that the same for New Hampshire? And then the question is how that figures into the budgeting process from the standpoint of not only the birth rate changing, but probably demographically, on where the births are falling in, relative to the cutoff rates on income. So do we see, we're certainly seeing a shifting to the elderly end of the Medicaid and Medicare. So are we seeing some kind of a shift in the other direction on the youth side of this?
So in terms of birth rate, the last report I saw on that was New Hampshire actually had stabilized and was one of the few states that hadn't declined. Now, there may be another year of data that I have not observed yet, but that was coming out of the pandemic. But our births have been pretty consistent around 11 to 12,000 a year for quite a bit of time. But when we look at some other information in this slide deck, compared to other states, even our neighbors like Vermont and Maine, New Hampshire generally has a higher economic status that gets reflected in the federal share that those states are paid. New Hampshire standard Medicaid is reimbursed at 50%. Other states are like Maine and Vermont are above that number. And I have a chart later on here that gives you an actual comparison. Look up the page number if you want. That we actually can demonstrate to you why that I think that New Hampshire has been able to support the fifth highest eligibility level at 323%. The national average is 255. And so, we probably do have more families that are, I'll say, better off, not well off in terms of.
Representative Nalvanko, if you could just maybe move your microphone closer to you. I just want to be sure that YouTube and everybody watching and all this and sees this in the future picks up what you say. Thank you.
David, help me find a page. Actually, that's not the one I was looking for. I was looking for the map that compares the different states in the region. Yeah. Yes. Yeah. Page 50 of the slide deck. You can see there's a map on the left-hand side and then a comparison of different states' federal matching percentages. You can see Maine was over 60% and Vermont is just under 60%, which is, when you count that times billions is a lot of money. We're in the same company as Connecticut and Massachusetts in terms of our federal match. Even Rhode Island, we're more well off than Rhode Island with respect to how the federal match works.
Just a quick follow-up.
Sure.
So the poverty rate here is comparatively better than some of the surrounding states. But when you factor into, I'm thinking about the demographics of where the childbirths are coming relative to the income levels. Again, trying to get at what the macro trends look like in terms of this overall program. It looks, is it having a downward slope on it compared to when we look at Medicare and Medicaid on the elderly side of it, we might be seeing an upward slope.
So I think in terms of the macro trend, I think the economic wealth of the state on a per capita basis has improved, and we are seeing fewer kids as a percentage of the entire program. Just as you see fewer kids in school, there's a bit of a trend there, but not that discernible, if you will. It definitely is not upward in terms of the number of children in the program.
Thank you.
Representative Priest for question.
Yes. By chance, do you have any information, any data of showing the children who are in the program versus those that would qualify, but for some reason are not in the program?
I don't, but I'm suspecting there may be some information out there that we could research that could help address that.
I would really like that information. Thank you.
We'll try to get that. Are folks okay if we move to the next?
Yes, we're now going to page,
We're going to page 16 of the deck and 888 of the governor's operating budget. And in Medicaid schools, we talked earlier about the grant. Here we're talking about the actual program that exists. And as I mentioned before, I think this is an area where we have seen a shrinkage in the program utilization. I think for a couple of reasons. I think the pandemic had a great effect on schools, but also, you know, to be compliantly participating in the Medicaid program that in 2018-19 timeframe, the, if you will, the rules that schools need to follow got a little bit more complex for them to follow. And I think some schools may not be have the technical expertise to master the program. And so I think the grant could be helpful to turning that tide some. And, you know, I think here we have budgeted for an increase. I think that HB2 language in prior sessions has allowed the department to come back to request additional funds if need be. They're 100% federal funds. I understood the other day you discussed this point about, you know, wanting to monitor what is happening in this program. We'd recommend, I think, reporting over other means to sort of track what's going on. We report once a year. We certainly could report, you know, quarterly if that was a preference, as opposed to having to enact legislation. But, you know, we'll work with whatever you give us to work with. Any questions in this area?
Representative Wallner.
No, I should know this. How does the school districts, the school is paying a portion of these services, and then a portion comes through Medicaid to schools. How do you account for that?
So it's actually quite simple today.
Good.
They provide a service like a physical therapy treatment. They bill us like any other provider would bill us. Often schools are using a billing company to support them, but they send in a claim. We pay half the claim, and the other half is assumed to be their contribution for the federal match. And that's what I was getting at earlier. Is I think our rates may not really approximate half their costs, and so I think other states that have converted to the methodology that will be required for us to have seen a benefit to their schools in terms of what they're able to get in Medicaid funding.
Okay, great. Thank you.
Would it be okay if I move to the next? So we're going to Medicaid administration, which is 7937, and on 889. And this one is one where I'd really like to give some concepts here. The largest line item, which is on 049, transfer to other state agencies. This is really not an administrative expense of the Medicaid division. It represents the federal claiming to pay New Hampshire Hospital and historically Glencliff and also Hampstead before it changes. And the reason you see the reduction between the current years and going into 26 and 27 is Hampstead will no longer be eligible for this type of funding. But basically we're drawing a federal match for the uncompensated care disproportionate share funding, and we transfer once we make the claim. It goes, so it's really, if you will, we're not incurring an expense here. The other thing I'd like to say about this unit, and we'll have a little bit more detail on this later on, is in terms of our contract lines, we've made a 25% reduction in our contract expenses for this upcoming biennium in the governor's budget. And I'll also point out there are a couple of really important contracts that have ROIs of 15 times their cost. And one of the expenses in this line is how we generate our pharmacy rebate. It's our vendor that we pay to generate pharmacy rebate. We pay a little under $200,000, and we're going to bring in, 30 million roughly in rebates, or maybe more. We have a contractor who checks the spending of the MCO's medical loss ratio, and we have a vendor that I gave the example of. Was we spend a little under $200,000 a year on that vendor and bring in like $3 million in the current year. I meant previously to say in the pharmacy side we spend a little under 2 million and get 30 million. Sorry, conflated those two for a moment. But generally what we're seeing here is that the contracts that we're entering into are ones that are generating value to the state. The other big item in this area is our actuary to help us develop our rates, and both the medical side and the dental side. It's the largest contracts that the state enters into. A point or two of accuracy is real money. And that one, I think the return on investment there is not as easy to calculate, but I think, we've been pretty consistent of being able to work within the means of the Medicaid program in this area, and, with a very, very small margin to account for a variance. I'll stop there and see if there are any questions.
Representative Stringham for a question.
Yeah, just on the contracts for program services, do you find that there's any areas in there within those contracts where you could both improve quality and increase efficiency by bringing some of the work in-house rather than doing it through contracts? And if so, where would that be?
So the three major ones that I gave as example, the pharmacy rebates, no, I think that's a specialized technology area. And the medical loss ratio, no, because I think these companies do this every day. And an actuary, our actuary is the largest actuary in the Medicaid space in the country. They do 30 states, and that I just don't think we would be operating alone would have that level of expertise. We do, I think, a good amount of work with our team, both in finance and Medicaid that we can do, but that there's very little dollars here that I think would work in that fashion.
And I think it's also just to highlight this, because we were talking about HB2 earlier. So in that 102 contract, there is an impact of an HB2 provision that will be in the final HB2 that comes out. And what that's doing there is effectively over the biennium reducing that line by $1 million. It's 500,000 each year. It's 50-50. And it's a directive to reduce the actuarial contract so that we only conduct one rate adjustment each year. Typically, we do 2 rate adjustments, one at the end of the state fiscal year, one around December timeframe. And so there was about $1 million total funds and cost savings generated by that HB2 provision, and that's been reflected in that 102 line.
Representative Nelvenko.
Thank you, Madam Chair. So just so I understand, so to the extent that you have the savings, is that showing up as a net number in the contract line, or do the savings, the refunds, I guess in particular? So you cited a couple of vendors that result in one was a refund on the prescription drugs, and
The rebates show up in a different spot, the drug rebates.
and what about the other savings?
So on the medical loss ratio in the dental program or the MCM program, that would come down to net the expenses in those areas.
So one of them is already reflected in the numbers that you've got in there and the costs, and the other one shows up somewhere else.
Yeah.
So the rebate savings are in accounting unit 7948 in agency income 007.
Where would I find that in, what page? Are you
It's
looking at?
on page of the governor's operating budget 891. We will be going through that, so we can certainly talk about that rebate revenue when we get there, though. That's easier.
Okay, and 892, but we'll get to that as you say. Okay, all set to proceed.
Okay, thank you. So going to the very bottom of 888, 889 to 890, state phase down, which is on the top of slide 17. So in the Medicaid program, there are certain seniors who also have Medicare coverage. We call them dually eligible for Medicaid and Medicare. The state picks up some of their costs for prescription drugs. And that amount that has to be picked up is by each state for these people who are dually eligible is a number that we don't get to decide. It's a, if you will, like a premium we have to pay. We're paying, in the amount that we end up having to pay is unfortunately not in sync with the budget. So we make our best estimate. The last increase, I think, was 8%. As you know, prescription drugs, if you have a Part D premium, they're not going down. So in part, we've made our best case estimate. And if I'm remembering correctly, we're paying about $273 today on a monthly basis per person for that coverage for those individuals. Yep. So it is it's one of those expenses that we really states do not have an ability to control other than through trying to keep their people healthy, if you will, and the amount of drugs that and number of people on the program.
Representative Priest for a question, and then Representative Stringham.
Thank you, Madam Chairman. On page 889, on item 049, transfer to other state agencies. What is that?
So earlier I was mentioning that the uncompensated care or disproportionate share funds that are paid to New Hampshire Hospital, Glencliff, and formerly Hampstead, that's where those transfers run through. So it's really, as I was saying, it's not an administrative expense per se. It's just the accounting of how the money comes in and then gets paid out.
And when we get to New Hampshire Hospital and Glencliff in a couple of weeks, you will see the corresponding revenue line item.
Right, you had reviewed that earlier. It's a little deceiving, but thank you for that clarification. Okay, Representative Stringham, followed by Representative Tulersky.
In terms of the Medicaid program in the pharmacy, do you have any flexibility on what drugs are included, what price you pay, whether there's a cap per patient? How restrictive is the federal program, and do you have to be in this program to be part of Medicaid in general?
So I think going back to the number 3 on that list sort of gets to a little bit to that. Under New Hampshire law, there's a requirement to use generics first, which I think generally would make sense, except in the world of Medicaid, where rebates are larger. And so what we're asking for in legislation, I think Senate Bill 119, I believe, is a version, and the governor is asking in her budget, is to include this. And I think when I was watching Representative Daniels, you had a question, does that increase the cost of the federal government? Actually lowers it because they pay their federal share. So if there's less expense for the state, the amount that the federal government would have to pay would be less as well. So it's I think a double win, if you will. So what that we're asking for, it's not always the case that with rebate, we're asking to allow the department to, where it is more favorable to the state and to overall healthcare costs, to be able to access a brand name drug. So getting to your question regarding, in order to participate in the federal rebate program, you do have to have on your formulary access to FDA-approved drugs. That being said, states can develop utilization criteria. There's a runway for states, I think typically 6 months before they'd have to include it in their formulary. You can develop different criteria. You're not forced to just hand out pills. It can be based on appropriate clinical utilization criteria. Medicine in the Medicaid program has grown since I've been in the Medicaid director a little over 7 years. When I first came in, it was about 18% of the medical spend. Today, it's 31%. So it's an area and when we did the reprocurement, that we restructured how the state shares that risk with the MCOs. There's also, when I first started the program, up till 2 or 3 years ago, there'd be like 1 or 2 of these very expensive gene therapies or biological treatments. Last year, when we developed our budget, in 2024 managed care rates, there were 66 new therapies of over $100,000, and the velocity of these coming at us are incredibly high. We've fortunately, have not, a lot of these are for rare conditions, but they're, Zolgensma is an example of it, that acquiring that therapy before rebate, the cost of the therapy alone is $2.4 million for treatment. Now, what that does is a child that has Duchenne's dystrophy, they won't have it. And think about what the lifetime cost of caring for someone for 20 or more years. And you have to get it in a certain interval for it to be effective. You have, in that one particular one, need it by 5, or after 5, it doesn't work. So these are very important issues to individuals who have these rare conditions. And that's why we want to run the program not just efficiently, but effectively, so that we can bring the therapies that would bring benefit to the public, but also to, manage our costs the best we can. Excuse me, I think I'm eating some more water.
Sure. We do have questions in the queue. Representative Talerski, followed by Representative Novelko. We're now at the 3 o'clock, just about the 3 o'clock mark. I see we're on slide 17. Just want to make sure you're running like you want to be running.
I think we're getting through the important parts, and we're almost done through the governor's budget. A lot of the rest of the material can move a lot faster, I think.
Okay, and let us know if you need a break.
Yeah, I'm talking too much.
As expected.
Yes.
Okay, Representative Talerski, Representative Novenko, you're on.
Thank you. Thank you. I want to thank you again for the amount of time and information you're giving us. This is not an easy task. I originally had raised my hand because I wanted to continue to bring attention to the mystery document here, because I thought we were hitting bullet 3.
Yep.
Appears I was correct. Can you just clarify, though, that this section on the acquisition of generic and name brand drugs is already included in the HB2 trailer bill draft that we have seen?
Yes,
Great.
it is.
Okay, thank you for that.
That one is.
Representative Novenko.
Yeah, I just want to take the opportunity to, again, thank you for the presentation materials. It's difficult to follow this stuff jumping from one document to another, but I think this presents it in a way that we can cross-reference the material to the various documents. And my question is on 890, and probably this is the same kind of a question, and I just wasn't paying attention, but I'll ask it anyhow. The drop in the hospital uncompensated care pool is just a shift from one place to another? Is that?
Yes, I think this is probably the most we're dealing now with the uncompensated care fund 7943. Thank you very
Yeah,
much.
that's right. Line 515 on, I guess, 890.
So the concept here, and one of the, I think, questions that we received from committee member, what you see playing out here is how the uncompensated care program is evolving. At one point, and for decades actually, at least two, New Hampshire would collect through the the Department of Revenue Administration, what's called the Medicaid Enhancement Tax, or assessment. It's basically a 5.4% on hospital services, and by hospital services, it's as defined in a Medicare cost report as hospital services, and that money comes to the department via the Department of Revenue Administration. The state makes a federal claim on that at 50%, and then a portion of that historically has been 91% would come back to hospitals, not each one getting 91% of what they paid, but based on the amount of uncompensated care they would tap into the pool. Over time, rules around this have changed federally, and it's become advantageous to what's not paid out to the hospitals helps support other providers, and in that 7948 account and others, and supports the Medicaid program. So 9% of the amount, equivalent amount, comes to the state as, if you will, an extra to the 50% match they had. That 160 RSA 167, I think 18 is where you find the law that's that sort of governs how this money is handled and paid to the hospitals today. Today the language in the law doesn't define exactly it. It defines about how the money comes in, how it's protected, but the percentages that come out is something that has evolved. There was an agreement that was codified in legislation in 2018. That legislation expired. Last session, there was an attempt to come up with a new agreement. There was not an agreement, and then the governor and commissioner have you might have heard about an 80% of the federal match coming back to the hospitals as opposed to 91%. So getting back directly to your question, and what you're seeing in the numbers here is that it's been advantageous not to pay to all the parties, not to pay out the money through traditional uncompensated care, but to pay it through related to Medicaid services and the uncompensated care associated with that, and people who have no insurance. And what we've done here is that we've increased, for example, on hospital rates, inpatient rates, the amount that went from, say, the average case may have gone from like $3,500. Today we're paying over $9,000. Where that difference is coming is shifting it from uncompensated care category here to provider rates in 7948. What that allows us to draw is a higher federal match on those dollars, which makes more money available to support the Medicaid program and more available to work out in the uncompensated care program in terms of the dollars. The percentage that each party gets in that I think is still subject to, in the governor's budget, it's 80%. That's where it stands today. I'm expecting that there'll be more conversations in the legislature and with the governor and the hospitals about this topic. But what's represented here today is the 80% approach. And what that means is some of the dollars that would appear as going out at that 50% match are now in the other parts of the budget, 7948 being the largest, that where we're paying out higher rates as opposed to uncompensated care. So instead of getting a 50% match, we might get closer to a 60% match. In the granted advantage space, our match is 90%, and paying out in rates there, the match instead of being 50 is 90. And so some of what's formerly in this account is now in granted advantage, which is to say this is hard to follow because one, we're moving dollars to the area where it's most advantageous in terms of the total pool of money, and secondly, that there's a part of the money that is now part of granted advantage, but that's all. We can all account for all of it, and we can certainly demonstrate it. But I just, as you're looking at this, say, why are the numbers changing so much? It's because of that dynamic that's playing out right now in 2025 and will play out in 26, 27.
Okay, we have
Just a-
Representative,
Just a real quick, so are you using an algorithm or something to optimize? This looks like some kind of a sub-program to optimize the matrix there, if you will.
Well, actually, no, but it's sort of like solving simultaneous equations because, give you an example, if you're a border hospital and the uncompensated care is based only on Medicaid, when you pay out pure uncompensated care, we can pay a hospital for New Hampshire Medicaid patients, uncompensated care, and let's say Vermont or Massachusetts, that we can draw a federal match on that. When you pay it out in rates, you can only pay it for New Hampshire patients. In the design of the payment plan, we've come up with other ways of adjusting for that. We've worked with the Hospital Association on modifiers for border hospitals to account for some of that. But in the end, from a hospital's perspective anyways, that certain hospitals, it's better for them to get some of their dollars in the traditional way because you can still pay the traditional way to all types of uncompensated care related to uninsured and Medicaid. It's something have spent a lot of time on trying to optimize, but it's not an algorithm. It's more of best fit, if you will.
There's more art than science.
It's art and science, yes.
okay, we're going to go Representative Daniels, then Representative Stringham, then Representative Wallner, then Representative Priest.
Thank you. You may have answered the question. I'm not quite sure that I had. But when you talk about the uncompensated pay, you're paying for the unpaid cost of care, who is determining that cost? Is it the hospital that says this aspirin costs $43, or is it the Medicaid that says it's 29 cents? And what happens with the uninsured?
So the cost is determined through a cost report. That it's a standard report with standard rules. It's the same report that Medicare uses to determine what the actual cost is. And then the costs in the uncompensated part is that the state also hires an auditor. We're required to hire an auditor to audit what the hospitals are representing as their costs. And the way that this program actually works is so that there's not a delay in compensating for uncompensated care. We make an estimate of what uncompensated care is, and then we reconcile it some period later, because uncompensation, as you could expect, sometimes it takes a while for that to play out. Someone may pay their bill over time. It may not be apparent within a very short period of time what it is. So it's something that's fairly complex. We have technical support on that on a weekly basis that we work with, and it's a highly sophisticated area. It's probably the most difficult part of the Medicaid program to comprehend, and it takes a team of people to work it. But we are audited by the federal government as well on our audits, and there are rules on this, and there's been litigation over time that have changed the rules. But just in terms of today's conversation, I think that the uncompensated care that we're providing is a standard definition, and it is not only looked at by us, but looked at by an outside auditor who's representing the federal government and how much they're paying.
Ultimately, it seems to be based on the Medicare fee schedule.
Medicare cost finding, yes.
Okay, thank you.
Yeah, thank you. The 7948, is that inpatient hospital services or what?
7948 covers a lot of just the managed care program, is the lion's share of that, which pays providers.
So the kind of rates that have, I mean, 2 years ago when we adjusted Medicaid rates, we left hospitals untouched at 0%. But now it looks like we've done a shift of 80 million or so from the uncompensated care fund to additional Medicaid rates. I guess through the managed care provision. And how much did those rates go? You said something about 3,000 to 9,000, or was that just a random, a hypothetical example?
We went, if I know you're familiar with this, for a DRG rate of 1 was around 3,000. It's now what was at the time set at Medicare levels, which is closer to 9,000 something at the time.
And
That's inpatient rates I was referring to.
yeah, so is the combination of these two things, in your view, adequate to keep hospitals solvent and whole at this point? Or are we still kind of going through additional adjustments?
I can say that the hospitals have testified, as recently as earlier this week, that they don't feel that the 80% plan is sufficient, and obviously they're doing quite a bit of advocacy work to try to change that where they can.
So I do understand, that instead of getting a 50% match, we're now getting a blended rate.
Yes.
The Granted Advantage 90% rate and the 50% rate for standard Medicaid managed care. What does that come out to be?
It's probably close to 60%, and it varies, but there's one other feature here that in addition to higher rates, we've used another concept called directed payments, which is effectively paying a higher rate as well, but we're allowed, particularly, and we've converted to this with the critical access hospitals, to be able to get them the most. That is where we're able to pay them based on an average commercial rate. Ultimately, it's capped at something like that. And so it can go even above Medicare in that instance.
Great, thank you.
Representative Wallner.
Just because I couldn't follow where all the funds were going in the 515 line. Can you maybe do a little chart for us at some point that would show us that we're going to find some of these now over in, adult and elder, or wherever they've moved to?
Yes.
Yes, we can absolutely do that. I think one of the easiest places to start is if you look at on page 890 in Accounting Unit 7943, the 005 private local funds. So that's the Met revenue that's coming in, and you'll see that decrease from 25 adjusted authorized to 26 on page 890 in Accounting Unit 7943.
Yeah.
And then if you turn the page and you look at 7948, you'll see that increase in Met revenue in the 005 line there, where it goes up to 283. So basically, I think that, just quick math, it's about 327 million in the first year of the next biennium. And we did include some increases based on the trends that we've seen year to date over the past couple of years. So,
Great, thank you.
of course.
Representative Priest for question.
Yes, just as again, a clarification. Again, on page 891 on the uncompensated care fund, you mentioned that there are transfers out of that fund into other line items or other departments, but I don't see any transfer of funds to other fund agencies that I've seen in other programs like Medicaid administration. And again, I just would like to know where these funds are going to. Thank you.
I think we can simply, I think the suggestion of a chart, we can give you a sort of a calculation of what types of funds are being used and where they're going. That would probably, rather than explaining it in words and pointing to this line and that line, I think a picture it's worth 1,000 words in this instance.
And just to clarify, Representative Priest, are you referring to accounting unit 7948, the 001 transfer from other agencies?
I'm referring to on page 889, item 049.
That's the transfer.
And then comparing that to the uncompensated care fund, where you mentioned that the reason why there is such large differences of funds from 2024, 2025 to 2026 is because those funds are being transferred to other departments.
Sure. So I think what we can do is we can put together a chart. Those are two separate issues, though. In one case, it's just so in one case, in the first instance, where we have the money that's going to New Hampshire Hospital, that's just showing in the budget. We're going to move that $40 or so million into New Hampshire Hospital, and we present on New Hampshire Hospital. You're going to see that revenue coming into their budget and the corresponding expenses. What we're talking about within the 7948 and the 7943 and 7948, what we're doing is we're actually changing the way that we're budgeting between biennia. So in the first biennia, you're going to see more of the Met revenue and in the first account, and then you're going to see it in the first year, and then you're going to see a much higher amount in 7948 in the second year, because the way we've crafted the budget is we're putting more of those dollars into the MCO payments and into the rates and directed payments. But we can provide a chart to help explain some of this, because it's not easy to follow given this document.
Yeah, because we're all over the place here.
Yeah,
So
yeah.
thank you.
So I would add to what Nathan was saying, what is on the line that you pointed out, that those funds don't come from the Medicaid enhancement tax match. State facilities get their uncompensated care on a different basis. And so it doesn't touch that at all.
Okay, thank you.
One important point for in addition to the kind of trying to get a better federal match where it's available, there's another big macro issue I would point out going on here. In 2023, Congress federally passed a law that the allocation to states of uncompensated care, called DISH, was going to be reduced. And we're all following what's going on now with Congress about the continuing resolution. Absent addressing this issue in the continuing resolution, New Hampshire's allocation for uncompensated care, and by the way, New Hampshire has, of all the states in the country, has used more of the DISH program than any other state as a percentage. We would go from over $200 million allowance for being able to draw to under $100 million. So we would see a drop going from 200 and something million to, I think, 92 million total. So part of the reason we're migrating out of the pure uncompensated care is because the program will be, the uncompensated care program, the DISH program, is going to be eventually, by federal law, is going to be shrunk in size. And to be able to support the level of funding we have is not just a exercise of trying to operate within the parameters of what the law is today, but where it's going. And I think the hospitals in the state are aligned to a large degree that we do need to make this migration, because that aspect, if it doesn't happen this year, like other things, sometimes Congress continues to delay, but eventually there's a big risk in terms of the amount of money that would be available drawing in traditional ways. Okay. You ready for one more? 7948, which is on page 891, right?
Right, page 891, governor's budget.
So this is the biggest account in Medicaid. This is where we're paying our managed care rates, which then, just so you know, about a little over 90% of the rate that we pay to the managed care companies is intended to pay providers. So it's like in the current managed care contract, it's about 90.2% on a blended basis of the dollars that go to them as an insurance premium, if you will, capitation rate. 90% is the target amount to pay out to providers, and that's that 101 line. The 535 line and the 563 line represent support to where Medicaid is allowed, and I call it braided funding. I think that's what others would call it too, where we're using a combination of different types of federal funding to support DCYF and other justice-involved children, which is a practice that's evolved over time to help capture the federal dollars that the state is entitled to programmatically to support cases and that either need to be placed, out of state or placed into the community. It's combining the 4E funding typically and the Medicaid funding to provide the services and reduce the burden on the New Hampshire taxpayers. You see an increase there and a reduction. I don't know if you want to speak to that, Nathan, on the 535.
Sure. The out of home placements line, you will see a reduction there. What we have seen in this biennium is we are addressing some of the rule changes at the federal level relative to Medicaid funds that we're able to claim for certain facilities over 16 beds that provide certain services. We're no longer able to claim Medicaid dollars, so you will see a reduction there. The department did include a prioritized needs request to support the general fund portion based on the projections that we're seeing for the loss of Medicaid dollars. And we're going to discuss that later for the Division for Behavioral Health as well as the Division for Children, Youth, and Families next week when Marie Noonan comes in. We'll be talking about that prioritized need and this specific issue. But that program is actually funded out of 3 separate accounting units in Medicaid, Division for Behavioral, or that Division for Behavioral Health and Division for Children, for Youth and Families. And it's really one of the challenges there, it's really dependent upon the specific needs and what the individual child or youth qualifies for. So as Henry was saying, it might be Medicaid, it might be TANF, it might be 4E, or it might be 100% general funds. It's difficult to predict, but we entered into contracts for the first time about 3 or 4 years ago. And this downward reduction here is to account for some of the changes that we've seen. So.
Representative Stringham for a question.
Just a clarification on the contracts. Are we at risk for services over running above the contracted amount? And if it goes under, are the managed care contracts limited to a certain gross profit margin?
I guess the answer is yes and yes, but let me explain. So we have, similar to the dental contract, we have a minimum medical loss ratio. Actually, in statute, it's 85%, I think federally, and we actually have a tighter one than that. Through the pandemic, there was a lot of expectation of how high costs would be or not. And so we had, on top of that, a risk corridor. Today, the targeted medical loss ratio provides for a 1.5% margin. The most it can be above that, based on the current contract, And that can evolve over time as the risk becomes more stable. But as it's existed over the past few years and in this current year, the additional profit potential is up to another 2.5%. So 4% would be the maximum that an MCO could earn under this contract. There's a 7.7% administration allowance. Both of those are tight to what you would find out there. New Hampshire prices, pretty aggressively but solidly in, when we've had our consultants and looking at, for all the times that we've had these risk corridors, the state at least 3 out of 4 times has benefited and has benefited more. There may be a period where we don't benefit, but there was a lot of unknowns, and where there are unknowns, we try to balance that risk between us. And we also follow, we talk to the federal actuaries, because while our actuaries do the work, then the federal actuaries do their review of their work. So it's a highly scrutinized area. I think that it's pretty lean. We have a price limitation and then a budget, and in all periods we've been able to stay within our budget, but not with a very large margin forever.
Representative Nelvenko for question.
I just wonder, so the shift to a different model, I wonder what you think that's an ongoing process, I assume. So
Yes.
you're incrementally doing that as you go through the biennium. So I just wonder what your sense of what the additional upside potential exists for optimization, if you will.
So I think we see for all the years that we've been doing this, and every year going forward, I think there's always room to improve what we're doing. The areas that we're focusing on in this contract were the big movers. We had the prescription drugs and the gene therapies, trying to deal with that differently. But on top of that, and on top of trying to do better in rebates, we're also trying to do more with what we call polypharmacy, which is when someone's on a lot of drugs. And, if you have family members, or particularly older members, that sometimes different doctors are prescribing medications and one doesn't know what the other is. And you can see someone on, 30 drugs. I'm not exaggerating in that point, but what we're trying to do in this program is to strengthen the identification of those cases, the review of those cases, and using the New Hampshire doctors to be more involved in trying to make therapeutic changes where there may be what we describe as iatrogenic disease caused by the care that you're delivering, is to make sure that we're not doing that. So that'd be an area that, buying the drugs at a good price is one thing. Utilizing the drugs clinically appropriately is the other half of it. And so we're working both sides of it, and we're leveraging what the MCOs can do and leveraging what our physicians and providers can do. And that's an area that we have retooled in this part of the this most recent procurement. So that is a very large percentage of our budget. As I said, it's 30. It's going to probably be by the end of next year, probably a third of what we spend. Then we've also focused on preventative services and strengthening the funds that go to local doctors for doing more in the care coordination and preventative services. Because when you look at the literature, there are a lot of things that save money, but a lot of them are kind of ephemeral, if you will. And the ones that do seem to save the money are the preventative services. And so we're putting more emphasis on prevention and an authentic relationship between the patient and the provider, where we don't want just a name on a piece of paper that's your doc. We want them to be actually being seen and evaluated, and we've also in the 2.0 procurement and the 3.0 procurement, we've had what we call remedies, where if there's a lack of performance, we can apply financial penalties to make sure that we're getting the value out of it. And that seems to make the program stronger in terms of holding the insurance companies, to the standards that they've signed a contract for. So we're continually working on different areas. Another area that we're working on is strengthening third-party liabilities, coordination of benefits, subrogation, COB, coordination of benefits. I said third-party liability, strengthening those where Medicaid shouldn't be the primary payer. Like if you think about workers' comp, sometimes it should be medical and sometimes it should be workers' comp. It's making sure when Medicaid is the payer, it is the correct payer and the correct order of payer. So those are things that we're doing, and we're trying to strengthen what the department offers there. And I could go on for more time than we want to talk about all the little areas that we're tweaking all the time. But the only way we're going to make it work in terms of the budget that's available to us is to continue to try to move the needle on a number of things. Lead testing is another one. There's been lead testing in the news. We've now working with public health and with the MCOs and have financial penalties and rewards for getting to a better level of lead testing. And, Dr. Ballard was our medical director, was on the news talking about how our rates of testing have started to recover after the pandemic. So
If I may, just a quick follow-up. So I assume you're leaning a lot on IT services to manage some of these complex, as you said, this really multi-factor equations. And one of the questions that I think Chairman Edwards had asked in a previous session with the IT people was, is there anything that needs to be done to kind of supplement the services and then in turn get a return on that investment in the whole area that you're talking about?
So third-party liability that I was speaking to is one of those areas where we're taking a step in this budget, is included for us to do what we call data matching, and then to take it further in a future capital request, to be able to do even more than what that level of service would allow us to do.
I mean, it sounds to me like an area where AI would be a significant benefit in pulling all that together, but that's just an opinion.
Yeah. No, I mean, AI is being used more in technology. One of the issues and the challenges in Medicaid for vendors is when you've seen one Medicaid program, you've seen one Medicaid program. So, it's not like taking software off the shelf and saying I can use it in all 50 states and the 6 territories. It's the customization to states that makes some of this more expensive than you would hope. But we do have some more of that later on in the presentation.
Okay, you may proceed.
Okay, I think actually the last one is the Medicaid information system. Let's see here. It's on 892. One of the things I'll say conceptually about this area is that, our Medicaid, and it's 8009 is the account number, Medicaid Management Information System. We're actually talking, you hear the term MMIS, which has been our historical term, and then you'll also hear the term Medicaid Enterprise System, MES. And that reflects sort of a movement to, rather than buying one system to address all your needs, is to be able to have some modularity, to be able to have more competition in terms of the applications that you have. And that's, the direction we're trying to move in an intelligent way. One of the, in terms of this budget, I would say that when you think about that, over probably close to $2.5 billion worth of claims in one way or another flow through our MMIS system, when you look at the general fund costs that are invested in this, while it's a large number, 11 million something, it comes out to less than 0.5% of the claims paid. And when you look at our administration in the Medicaid program, the other part of it, it's about 0.5% as well. So, I mean, I think when you look at the people part and you look at the IT part, one could argue that maybe there's underinvestment there, but I think I'm not representing that. I'm saying, you know, we're trying to progressively improve and get advances there to try to take advantage of other technologies. Probably more where we're seeing AI is in the eligibility side, which is not part of what's in the Division of Medicaid Services. We have the Medicaid information system. And the way that the federal match works there is typically on the capital side, which I know is not part of, it's divided up differently in the House, but generally acquisition is approved at a 90% federal match, 10% state match. And then there's a period of time in installation where it's 50-50. And then when the system is certified, you get to 75-25. Part of what's in the Medicaid budget here is also, in this particular department, is an entity called NTT, which, because CMS is putting so much money to states, they require you to have like a clerk of the works to make sure that the investment being made is sort of what's expected to be installed, that they're looking to make sure that their investment is being protected. But what we see coming in on, and we'll have, I think, an exhibit later on here, is the migration to modularity begins with a system integrator functionality, that how you're going to interface all the different modules in a way that they can speak to each other. So, you know, we've been working to study the best way to do this, looking at other states. What we've found is other states that have begun with something other than the system integrator first have paid to regret that. And so we're currently in the process of a procurement there. And that, I think, begins our effort to be able to create more opportunities for better pricing potentially than we otherwise would have, and to be able to bring in new technology. In terms of this budget, as I said, I think that there's some extension of our event notification system, the EVV system, which is what allows us to see what services are provided. That both has a benefit to us knowing that patients have received services, but also is also a tool of fraud, waste, and abuse to look for that. So I think in terms of what you're seeing here is some increase in costs, reflecting, you know, us stepping up on the modularity space and further deploying some of our technology that we already have more widely. I'll take any questions you have there.
Real quick one is, if you saw reductions in number of Medicaid recipients due to some of the things that we're putting in HB2, would you see a reduction in these numbers? Because generally there'd be fewer people getting services, and about the same. Is that where one place you might see a change in the budget?
There's probably some small components, like when we go to get data from an outside source. If we're doing that less frequently, there's usually a per click kind of cost in some components, but the majority of the system is sort of like a sunk cost. We have what we call a fiscal agent that interfaces with 35,000 providers, or nearly that number, that are enrolled in the Medicaid program. You know, whether you have 34,000 or 35,000 providers, or 185 or 200,000, it's not much you can do there in terms of those costs.
Okay, proceed, Mr. Lippman.
Thank you.
I was going to suggest, maybe 5-minute break, especially for our speakers too, but I know I have a hard stop at 10 o'clock tonight, given the rate that we're, no, I'm kidding. But
Okay, are you okay with that? 5-minute break?
I am, keep, whatever you want to do, we'll be prepared to do it.
That sounds good. We'll be back in 5 minutes. Thank you.
Thank you.
Okay, Division 3 work session on February 21st is going to come back to order live on YouTube. Thank you, Mr. Lippman, Mr. White, and also joined now at the table by David.
David Shorney, the Deputy Medicaid Director.
Yes, make yourself at home if you'd like to sit there or take one of the other seats, up to you. And we'll continue where we left off. So I believe that was at page
We go to 19.
19.
But if we could, Madam Chair, in terms of covering this before we go further.
Okay,
There are two items.
is that the document of 5?
Yes.
Okay, and we are going to return back to that too at the end as a wrap up. But yes, if you'd like to refer back to that, which number?
Just in terms of the, in 79, let's see, in 8 would be 890, the pages where.
in the governor's budget?
The governor's budget, the chip is 79, there's 7948 is the standard Medicaid program, and 79,
This is 7051.
7051 is the children's program.
Okay,
So in terms of the prescription, which is number 4, the pharmacy cost sharing, so within the dollar amounts there is an estimate of what would be collected on prescription drug copays. We do have copays in place today. They've been $1 or $2 for more than a decade, and when you consider inflation, they're probably like a quarter and 50 cents today in terms of and so the allowable levels for copays are $4 for preferred and non-preferred drugs is up to 8. We chose here, I think, to look at $4 for a couple of reasons. One being that the concept of trying to use the lowest net cost, it could get confusing over time, which is preferred or not preferred. So we'd rather have the preferred drug list. The other issue there too is that I mentioned earlier on in the presentation, we're trying to implement these issues, if they're passed, in the simplest way without having to incur major IT costs to get them situated by having one. I think it'll be simpler to administer and to program. And 2, because of that 5% cap, when you're talking about, it's not just the premium, it's any copay. So what we're suggesting is that where we're charging up a premium, not to have a copay on the medicines, so we don't have to add system complexity and logic to track all these different dollar amounts. So the $4 copay would apply to people who weren't paying premiums.
Representative Wallner for a question.
That was my question. Would families who were paying the premium also be paying $4 now?
No,
No.
and
So
I
would they
think
pay 0?
they would pay 0. Their
Okay.
premium would be their cost sharing. If we were to implement tracking it separately, we wouldn't get it done very fast, and it would be a lot of dollars to probably get it done because it'd be a major change.
Right. Thanks.
Sorry.
Representative Telarsky for
So
a
just
question.
thank you. Just to help me process this. So the people who do not have a premium, so the ones who fall below the federal poverty threshold, are going to be the ones that have to pay their $4 at the pharmacy, pay it to the pharmacy, pay it.
Yes,
To the
today
state.
today there's $1 or $2.
Yep.
Instead of $1 or $2, it would be $4, except if you were a participant that was paying a premium.
Okay. So, sorry, one quick follow-up as I'm processing this. So, how would keep track of those copays on the pharmaceutical to then get up to the 5% of income if necessary, if they got to that level?
Yeah, it's very, we have to have a control in place to make sure, but with the $1 and $2, we usually get nowhere near that. And I think the $4, it's not de minimis to the individual that has to pay it, but it's fairly de minimis in the scope of what the costs are.
And one last question. you talk often about these extremely expensive therapeutic drugs. How does that play into this in this situation?
So a lot of those, like the Zolgensma example, which was the most expensive one we've ever experienced, they come with hospitalization, and
Okay.
so in those instances, the drugs are part of typically an inpatient admission or a hospital outpatient visit, so they're not like what you would go to CVS or Rite Aid or
Yep.
or Walgreens to pick up a script.
But even beyond that, if you have someone who's on some kind of more expensive medication, maybe something that's a couple $100
A month.
a script or whatever,
Yep,
it would be that $4.
correct. And then number 5 is the Granted Advantage program. Typically, premiums are not allowed when you're paying under, when the federal poverty limit is below 150%. As I mentioned earlier, the average tenure on the program is under a year. It's like 302 days, I think, currently is the average tenure on the program. Individuals who leave Granted Advantage often are then their choice of coverage if they're making more than 138% of FPL, which is not hard to do in today's economy, if you will, in New Hampshire employment space. They often would migrate to an ACA product, and there they're going to have copays and deductibles. And I think in part, I think it prepares individuals for the fact that healthcare, when you're outside of Medicaid, does come with cost. And it would take a waiver to get an exception from the rule there to do this. So we have no expectation in 2026 that would occur. That it would take us time to work through the federal process to get that. And again, there are a lot of details in terms of, well, what happens if they don't pay, or what happens if they're in the middle of the treatment. The same issues with the children, types of issues that we'll have to work through are things that we need to work through there. But I think that doing a premium is preferential to cost sharing, because then it's at the provider level where I think you run into access issues. You know, if you're that you could argue the other way, but I think in New Hampshire, our experience has been that when you've tried to do copays and emergency for non-emergency care or other things, it just adds to the bad debt that the providers are having, and they're less willing to maybe accept patients who are on Medicaid. So I think if there is going to be a premium and cost sharing, this is, I think, the best way to preserve access to the providers. And I know there are probably differences of opinion as to whether a premium should be there at all, but if there is one, I think this is the best way to do the cost sharing.
Representative Stringham for a question.
Yeah, how many total patients are in this block, and then how many in the 100 to 135% range?
Great question. Do we actually have a slide on that? Or, well, okay, but we'd actually, when we did the 101, there is one. There's about 10,000 individuals who are in that 100 out of the 60,000 that are in the 100 to 138, if I'm remembering correctly. And the majority are below 100%. And so they would be only subject to the $4 copays for prescription drugs.
Thank you.
If you give us a moment, we can look that up. Oh, you just want to.
Yeah.
So actually 11,000.
167.
11,167 when we ran the report out of the almost 60,000. So about 17%.
Representative Wallner for a question.
So the one thing about Granted Advantage is that this is a program for very low income people who in the past could not afford private health insurance. And they probably used they didn't have their own doctor, they maybe used the emergency room more or urgent care centers more. That was where they were able to get their care. Have you seen some studies that is showing that they're more likely now to be using their own physician, getting preventive kinds of services? Are we saving money actually because they use it in a better way?
I think that the studies suggest that for an individual that to be access care at the appropriate setting is advantageous to the cost of the system and to get care right time, right place. And you know, how we would set the premiums, we try to be as sensitive as we can to not making it go to the wrong place, the most expensive place. I think that we don't want to defeat the, if you will, the value that comes from some cost sharing to, you know, the budget that we're facing. So I think we try to be smart about, you know, there are other times that going way back where New Hampshire, for example, and maybe you have recollection of this, limited the number of prescriptions that someone could get. And there's actually a couple of national studies at New England Journal of Medicine that showed that wasn't such a good thing. And it led to more people being institutionalized. So I think you got to be careful about how you set these things so they don't have a boomerang effect that ends up costing more and leading to worse health. So we're going to have to approach this with sensitivity.
And just one other question. How much, I mean, you must have done some estimates. How much do you think the state will be receiving from these folks for their part of the premium?
Yeah, so it's factored into the budget. It's 12 million in the second year of the biennium. And again, we did not assume 100% collection.
Yeah. Thank you.
And they're on at current poverty levels, just to give you some scaling of it, it'd be about $750 at a 5% level. And
Representative Talarsky for a question.
So you didn't assume 100% compliance. What did you assume to get to that 12 million? I'm just curious.
I'm happy to answer the question, but I also am a little bit concerned about putting out the percentage that people feel that they wouldn't. But suffice it to say that there's a reasonable percentage of what we expect to collect. I don't want to put a number out there because I don't want it to be lower than it otherwise would be if that's the policy that's implemented. But, you know, we'd expect that a number of people are not going to be able to pay. It's not like 5%. It's a much higher number than 5.
Yeah. Thanks.
Representative Stringham for a question.
I mean, is your concern as if the number's 50%, you just don't want to say on Zoom that 6,000 people are going to lose their health insurance?
No, I think it's just more the collectability, I think if we're charging a premium in the program here, I think that in good faith, we want people to pay it if they can pay it. And if they can't pay it, then we're going to have policies to address that. I think it's just, don't want to set something up where we say we don't have an expectation to pay. And so I think, again, you know, what Representative Walner raised in terms of sensitivities around people who are in treatment, that we don't want to do something that's foolish in terms of saying, okay, you're in the middle of chemotherapy, we're not going to cut you off. We knock you off, and a month later you're back on. That doesn't make sense, right? So I think we do need to carefully design this and evaluate it in terms of what's the best way to administer it, so that the value that could be had from it, understanding some people feel like, and I think some literature, shows that it's not a favorable thing to have cost sharing, but I would say that there are states of both ends of the spectrum that do have premiums and have continued to have them. So I think while it's a policy choice to still be worked through the legislature, it isn't one that New Hampshire would be standing alone in, and it has been something we've done in the past.
Just a quick follow-up, the 5%, is that a ramp or is it a cliff? Like, if you hit 100%, you pay 5% of income, or is it 1% at that level and then it goes to
Unfortunately,
5?
it is a cliff.
Cliff.
Step.
The premium though would ramp between 100 and 138.
So if I could just summarize what you said about, in that 12 million number, what the assumption was, that what you're saying is that you're basing this on either prior experience in other programs or looking at other states' experience without disclosing what the number is.
Right. I think we do realize that there is going to be situations where it can't be paid, and we want to design policies around that as opposed to just setting an expectation that it's not paid.
Okay, thank you.
Okay, ready to proceed. We are entering hour 4, so I don't want to certainly rush. I want you to be able to say whatever you want to, but just keeping track of the time.
So on page 19, and in the break, Kevin Ripple asked us a question about a figure in 7948. I don't know if you want to address that.
So the question that Kevin had asked us, it relates to accounting unit 7948 and the specifically the adjusted authorized amount. And it's on page 892 of the governor's operating budget is where I apologize. It's on page 891. There we go. So on page, wait a minute. Yes, so on page 891, in the estimated source of funds, about 3/4 of the way down the page, you'll see the general fund amount, the actual expense in state fiscal year 24 being about $138 million of general funds. And then you'll see that increase there, the 226 number, and then you'll see it go back down for the governor's recommended budget. So the reason that you do see a large increase in the adjusted authorized is based on the existing state law that is applicable, and it has been for about 3 or 4 years. The Medicaid program is able to carry forward funds within the 101 class line as restricted revenue from one year to the next. And so on page 19 of the PowerPoint presentation that's before you, the net unencumbered general funds in 7948 is approximately almost $29 million once we take into account the existing liabilities. And the item that we did discuss that is in the HB2 document that we were looking at the other day continues that authority to carry forward funds from this biennium to the next. And part of the reason, historical reason for doing that here and other states do this as well, is because the Medicaid budget is in the billions of dollars. So while the unencumbered general fund amount is $28 million, if we have a slight change in the economy or some other change, or the projections differ a year out from where we started, that $28 million can get eaten up really quickly, because as a percentage of a couple $1 billion, it's a relatively small amount. I do recognize that it is larger than some other state agencies in totality, but we're also talking about the Medicaid budget, which is in the billions of dollars. So.
And I think slide 20, we've covered all of these items in the discussion, but if there's a question on it, we're happy to take
I
it.
do have one, if I may.
Representative Telersky.
So what I'm a little confused by something.
Okay.
So it appears that the issues that we discussed on the 5 bullet page document
Yep.
is included for the most part in the governor adjustments to the budget
Yes.
and not listed under the part that says HB2 items. And it seems to me that we have a whole lot of big bucket of policy changes that are going to come with specific details on things. And I'm wondering, where's that all going to land?
So I think in terms of, during the break, Kevin Ripple passed out this piece of paper I think OLS would probably work on these, and they might have some suggestions. But I think this would represent, it's basically 4 paragraphs of each of the items, except for the Granite Advantage one that is here, I think.
So to clarify what you just said, so this paper that got lost on my desk.
No, there was this paper passed
Yep,
out
it
during the
just-
break. Yep.
Yep. So 1, 2, 3, 4, 5 different little paragraphs there. You said this is probably the language it's going to be used, but it's missing the Granite Advantage.
Sorry, I stand corrected. That's the third one. Granite Advantage is there. So I think it covers all 5.
And this will be, sorry, and so just to clarify, it will be in an HB2 item, even though the slide says it's not.
Yes. So this is the language that we anticipate, or there might be some minor variations that will come out in HB2 that OLS will release. The HB2 document that we were looking at the other day did include the brand name versus generic drugs, but these are the remaining 5
Right.
additional policy changes that have been incorporated into the governor's operating budget. So the dollars that you see reflect these provisions.
Can I be really simplistic and ask you to, on each paragraph, just tell me what it corresponds to,
Yes.
the policy matters on the other?
So the first one is the $4 copay,
Yep.
which is item 4 on that sheet.
Yep.
The next one is basically an expense reduction in the administrative area. It's saying that we're only going to do 1 rate filing a year. I'm not sure that is, I mean, that's just I think an expense reduction, but just, then the next one is, the Granite Advantage one, which is number 5.
Yep.
The fourth one on that page is the children's that going, the 255. And.
That was number 2?
That would be number 2, and number 1 is the last one, which is restoring back to the regular eligibility redetermination. So the last one would correspond with number 1.
Thank you for that.
You're welcome. If it's okay, advancing to
Yes.
page 21 is basically provided, you've heard a lot and a lot thrown at you. This summarizes basically all we went over in terms of the major changes. There is that one adjustment that Nathan made earlier about that we need to correct the netting out of the expense and disclosing the revenue. But other than that this is faithful to what we went over as being the major points. So this kind of gives you a cheat sheet, if you will, to looking at all the other items. And then moving to page 22, these are the support the calculations that are in the governor's budget regarding the return to normal eligibility, which is number 1 on this sheet and number 5 on the other, and lays out the calculations there. Slide 23 is just a picture of enrollment. If you go to the bottom of that page, the grand total, the 177,420 is where we began where we had enrollment as of March of 2020, and the 185,448 was as of February 3rd. So you can see if you go to the top that we're within 0.4% of on the standard program where we were pre-pandemic, and with Granite Advantage we're 8,580 or 16.7% above where we are. Keep in mind the policy changes of continuous enrollment for children, the postpartum coverage of 12 months continuous enrollment. And I think that what we've observed, which will come up in a number, I'll point it out when we get to it, that we see more people using Granite Advantage as the entry point when they have disability or or postpartum situation or single parent, because it's the easiest one to be able to get the health coverage while you're waiting for other things to play out. Slide 24 gives you a longer trend line looking at each of the major eligibility groups. Again, be happy to answer questions offline if you have any on this, but in the interest of time, just gives you a longer look at it. The low point, which was sort of the end of all of our unwind activity, largely was November. You can see how enrollment has changed in each of the eligibility groups over time. Slide 25 is gives you a sort of a recap of what's allowable for premium and cost sharing. And picking up on page 26 is the number 2 on this sheet that was handed out earlier, and number 4 on the sheet that Kevin handed out. Sorry for that confusion. The detail behind that. And then the pharmacy cost sharing is on the bottom of that, which is pharmacy cost sharing is number 4 on the original sheet that was handed out, and the pharmacy cost sharing is number one on the HB2 sheet, if you will. Then the granted advantage premiums are on page 27, and that is number 3 on the HB2 kind of potential ones, and then on the original sheet that was handed out, number 5. And that's, you see the 12 million is, and just a little bit more description there. Moving to slide 28, in the AAU 7937, the administration, when I mentioned early on in the presentation, the 25% cut, that's just laying that out there. And as I mentioned, the ones we highlighted in green are the ones that have a great ROI for the state in terms of the spending, in terms of whether it's drug rebates or making sure the state's getting what it's supposed to out of its return on the managed care contracts. And then page 29 is the lowest net cost on the drugs, which is number 3 on the sheet that was passed out originally, and that's already in HB2. This one on page 29 is the one that is in HB2 already. And the reason that the dollar figure changes from year to year, because people are already on drugs and things like that, that it's going to take some time to migrate to get savings. We actually think the savings will actually increase in 28, because it takes some time to work through. You just don't want to tell someone, change a drug that they're stable on. So that's why we, and we also reference the Senate bill that addresses this too. Slide 30. It's just the trend in the Medicaid enhancement tax. I think we have seen that grow. At 348 was the number that was the preliminary estimate, which is an increase from 319 in the prior year, 24. And we've had mostly the preliminary estimate has been accurate except for the pandemic, height of the pandemic. And then on page 31, a little bit explanation of the MET and the directed payments and the uncompensated care payments, and just an example at the bottom of how, $10 million can generate different levels based on a straight match of 50-50 versus another match. Page 32 is basically the current way that the sort of the MET is deployed in the budget, if you will. So you've got the 25 year, which is the current year that we're in under the 80% plan. And then you got what 26 is based on estimates that were originally produced. As we can see already in 25 that the 26 years already been outperformed, and we're at 348 and the non-binding estimate. So hopefully this helps a little bit with the reconciliation of where the dollars are moving. Page 33 is an explanation of state phase down that you can walk away with. And then the number I had quoted earlier, 273, is currently what we're paying. Page 34 is a request that I think came from the chair to look at what has been added to the Medicaid program in terms of services and eligibility. We do have a handout that we can leave with you. There's a bit of work that has to be done to compile that. I think we've got all the changes. We haven't got all the dollars put together yet, but we can leave that with you and answer any questions on that.
That would be great. And then it can be posted to our website of information. Perfect.
Yep, if we could just put, it will be updated, and we'd like to replace it when it's fully, but at least you can see all the changes.
Sure.
And we also provide the statutory reference, whether it's state or federal.
Excellent. Thank you.
Page 35 is the Medicaid to Schools program and sort of reviewing what it is, the issue of transitioning to a different claiming methodology, and what while we talk about schools, it's really Medicaid's built on local education agency, which can, in a town that has multiple schools, can be in, like Manchester, for example, versus another town may only have one school or two schools. So they're all different sizes, but the unit that gets paid the dollars is an LEA. And then lastly, following that is on page 36 is what the participation has been and how it's changed over the years. The number ones that are to the right of some of the dollar figures there are the fact that there was also the federal match, the enhanced federal match that was available. At one point, it was, instead of 50%, it was 56.2%, that was passed on directly to the schools. So these numbers don't include that additional amount, but you can see the program has shrunk over time. And I think there's a real opportunity to changing this methodology, and hopefully with the grant to provide more resources to schools. And I think also we need to look at how special ed and Medicaid to schools connect in terms of dollars that are available federally versus, but I know that isn't a 2-week exercise. Turning to
Representative Telersky for a question.
Thank you. The next slide is the potential federal implications, which I think could probably give us another 4 hours on a different day. But before we go there, page 893 of the governor's budget, which I think is the bottom line for Medicaid,
the 1.3 billion.
the 1.3 billion.
Yes.
When I look at the 2025 adjusted authorized, then go over to the 2026 recommended, I figured it's a difference of $71,609,664. And I don't expect an answer to this question, but I'm wondering if there could be some kind of graphic or chart that can be produced that tells us what is going away with that $71 million. How did we get there? In very sort of simple words, if I'm going to have to explain it to my constituents.
So I think the first thing that's important to think about when looking at that is you're not comparing the same numbers. So you're comparing the adjusted authorized amount and not necessarily the budget amount. And so the adjusted authorized amount includes that $94 million of carry forward that we were referring to earlier.
Okay.
But one thing that we could do is we could look at what was appropriated by HB1 in the current biennium. We can add in the HB2, we can try to add in the HB2 dollars and maybe the state fiscal year 24 legislation impacting that as well. And then kind of crosswalk that. And then there's a table, I think it was back on page 21, that we could try to incorporate in there as well. So you can kind of see what are the differences. I think another really important feature here is when we build our budget, it's we work with the actuaries to really look into the details to try to project as accurately as possible what the needs are, what the capitation rate is going to be, and what the total expenses will be as well. So we can work on trying to crosswalk this and get something that makes a little bit more sense, because I don't think adjusted authorized is always the best sort of comparative point.
I thank you for that. And I understand this is so super complicated, which is why I'm trying to figure out how to actually be able to communicate it to someone who hasn't been sitting in this committee room. Because I think what I'm hearing is people are really concerned, and they're really concerned about what this budget potentially could mean for their day-to-day lives and caring for their families.
And we want to be supportive of making it clear as we can, and so we will provide
Thank you.
to support you in that regard. So on page 38, we've identified some of the,
Representative Priest for a question.
Thank you. Going along with my fellow representative, Representative Turisky, given the time and given the important nature of federal initiatives and potential budget cuts and what's happening now in Washington, I think we should dedicate a time just to talk this through, because things could change within the next week.
Okay. My thought there is that we have bookings essentially for work sessions until March 11th. Is that right, Mr. Ripple? Is March 11th the last scheduled day?
It's the last scheduled work session. I believe we're going to add the Prescription Drug Affordability Board to the 12th, so there will be one more after that.
Okay. Let's see what we can do about adding
We
it.
have nothing next Friday, and I think if we have, and we could post it in the next journal, what? I mean, that's just an idea to throw out.
Yes, understood. My thought is perhaps we add it to the prescription topic on what day is that, Mr. Ripple?
That'll be on March 12th.
Possibly on March 12th, possibly. So let's keep that in mind,
Okay, yeah.
given the intensity of the subject matter today. It's really amazing that you can
It could all change.
continue
You could
for 4 solid hours. You've done a fantastic job, you and your team. But again, it just demonstrates just how detailed and extensive this topic is. Okay.
so without keeping in mind what was just discussed, I think on page 38, I think those are all things, if any one of those come into place, there's major impact on budget and coverages and so forth. The work requirement is a piece of legislation that the reason I bring it up here is there's an active bill in the Senate that has passed committee. It directs the department to implement what was previously vacated by the court and ended by. But I think part of the things that might happen as part at the state level, but also at the federal level, there could be a change in policy there. And what I wanted to point out, because it's a financial item, is that because it was all the work that we did IT wise, we maintained it, but if we were required to implement it exactly as it is today, and it is in statute today already, because it was ended and vacated, we did not keep it in sync with everything else. There would be a cost, which we identify as about 1.7 million in total funds, to be able to get it back in sync with the system. Beyond that, I think there's also a need to look at what Congress says about it. They may create an easier path. They may create, the new administration may create different standards than the previous administration. So what I'm trying to alert you to is just passing and saying us to do it again is not a free item, that there is going to be a cost associated with that. Whether what that would be is, I'm just alerting to you to that. It's not just resubmit and just start it up again. There are IT costs, and then there are also possibly staffing costs to administer it.
So just to add to what you're saying, that's Senate Bill 134.
Yes.
Currently, I see the docket right now, and it looks as though it's in the Senate.
Yes.
It has reported out of committee, ought to pass with amendment. So I would encourage everyone to look at the amendment number 0401 lowercase s, which essentially replaces the bill. It came out of the Senate committee 3-2, and it looks like it's to be determined on the Senate floor.
Yes. The amendment, effectively, they had us having to submit it by July 1st, which is pretty unrealistic if the legislative session goes to, June in a budget year. And they changed the date to January 1st of 26 would be the date that we'd have to submit it. So that was the major change that I think is the amendment. And
Okay.
just identifying, just on the side here, I'm sure it's a bill that probably would need an FN on it ultimately. And then slide,
Just
Representative Nelvenko for a
just very-
question.
just a very quick question, and because I haven't paid attention to this over the years I've lived here, but didn't we have a work requirement at one other point in our history?
so in 2018, SB 313 required us to apply for a waiver for work requirement. We applied for it, received it, and started to implement it. And then the court here in New Hampshire, and if you look at the next page, there's a map in the United States, color-coded of which states had an approval and which states were denied. And then on the right-hand side is a recap on Georgia currently, based on, I think, the district court in that area, were able to implement something. They're making some changes. Arkansas, which New Hampshire and Arkansas were approved around the same month, I believe. Arkansas is going back as well. We could certainly spend more time on this topic if in fact it has approval here and if there's federal changes. Slide 41 is basically some statistics produced by the Kaiser Foundation over a couple of year time frame that gives you some sense of who's working that's in the Medicaid program. Our work at the height of the pandemic, when Granted Advantage was like 97,000 enrollment, the number of people working was at 70%. Today it's less than that. It's around the U.S. average, a little bit better. But this gives you some sense of, from a secondary source of what it looks like in New Hampshire today. The next two slides on page 42 and 43. 42 is an example of looking at the two populations by who was enrolled in a given month. These numbers are a little bit higher than you've seen earlier because we're looking at anybody who was enrolled during the month. But that's just sort of the trend there, going all the way back to 2014 to fiscal year 25, just to give you a sense of what's been happening in the program globally. Then on page 43 was the point I was trying to make earlier, is that you can see that adults with disabilities, parenting adults, and pregnant postpartum women, that there are fewer, because we believe that they're taking advantage of the the opportunity to get health care sooner by going directly to Granite Advantage. If that were to, the issue here, right, for the state from a financial standpoint, when they're in Granite Advantage, it's a 90% federal match. When they go back to a standard program, we drop to a 50% match. And so, you know, there's a factor to consider in terms of what the net cost of ending expansion would be in terms of on the state directly as well as the insurance markets. Moving to page 45, this is sort of the appendix, but we had one prioritized need that got approved, which is a Project Walk program, which is individuals who have issues with mobility where generally the medical rehab wouldn't provide any further supports to help them be able to be more mobile, that this takes them a little bit further. It's something that was started in, I guess, the end of 2024, and it's continued in this in the governor's budget. And page 46 and 47. 46 is a slide we've used to sort of lay out all the things that we did on one page to help with, you know, keeping people covered who were eligible and supporting those who weren't. But the overall statistics of the unwind are what you find on page 47. And the grand total of the sort of the flesh tone colored line is people who retain coverage was just under 70% in total. But what we saw is that the people who were what we call the protected group, those are people who protected in the sense that they had continuous coverage through that 4-year period, up to the 4-year period, that they renewed at a much lower level than the individuals who were had come on more recently. And, you know, we're seeing there that they renewed at a rate of almost 84%. If we were looking at some more current statistics, we'd actually see with the ex parte renewal flexibilities that we're seeing a renewal rate approaching over 90%. But once the authorities for the flexibility go away, we're expecting that to drop by about 20%. And that's where some of those calculations of fewer people renewing come from. Page 48 is just a summary of the, you know, sometimes people talk about which programs that you should offer or not, and we highlighted the mandatory services, and the yellow items on the bottom of that chart, they're the ones that are considered under the ACA essential health benefits, and you know, things that we have covered in the Medicaid program is, you know, you wouldn't think, I think today, to not cover prescription drugs, and for children not to give them eyeglasses and who need it, and you know, even mental health is considered an optional service. But I think just provided this because this sometimes comes up when people talk about Medicaid. Then page 49 gives you some comparisons of New Hampshire's eligibility criteria versus the nation. I think, as we emphasized earlier, that with respect to children, New Hampshire has, you know, the 5th highest eligibility in the country. When it comes to other categories, we're about median. Then on slide 50 is the federal match, which we brought that slide up earlier. 51 is just an explanation of how federal match works. And page 52 is just a table of the different match rates, and on the bottom is an example calculation using $1,000. 53 is, I guess with time, I'm gonna this is the community reentry program. It's the 1115 waiver program. It sort of summarizes that. And on the bottom, it summarizes the youth reentry program, kind of the key features of those programs. again, I think if you're really interested in this, it deserves, much longer time than that, but it just gives you at least a basic on that.
And again, what you're taking us through is the appendix. So you've
Yes.
provided all this as supplemental to your presentation.
Yes. And then on 54 and 54 is some highlights of the reprocurement of what we did in 3.0 to make the program better. And then 55 gets into the things I talked about earlier on medication, the two major initiatives there in terms of within the more recent procurement. 56 shows the distribution of the capitation rate where the money's spent. You'll notice in the sort of the lighter brown area that the outside says 25.2%, the inside says 31%. The difference is the 31% is just of the medical spend, not the administration or profit component or the premium tax. When you look at the medical spend, it's 31% of that. Page 57 are trends on utilization in both the Granite Advantage program and standard program that we've been following over time. Their utilization rates per thousand. I know that was an interest of at least one member of the committee to have some insights into that. We can provide more, but this is sort of a high level, look that we do follow it, and are some links to take you to different places to look at more detail. On page 68 is the New Hampshire. This is something CMS tracks in terms of the number of measures that New Hampshire participates in. We're one of the higher ones. And then on page 69 is a summary of the federal scorecard of where we're not doing as well as we'd like to, that we actually have metrics that we're already working on to get better in. And then of the areas we're doing excellently, we have 9 out of 10 where we have metrics that we're tracking. We could do a lot more on quality if you're interested in that. Almost made 4:30.
Okay, thank you very much. I see that ends your formal presentation with the appendix included. So at this point, I'll ask for any wrap-up questions related to your presentation. I would like to also see if anyone has any further remarks on this document of 5 that was passed out earlier and on the website. Any comments on preliminary House Bill 2? And then anybody from the public if they would like to comment. So let's start with any wrap-up questions to the overall presentation at this point. Representative Daniels for a question.
Thank you. On the 255% threshold,
Yes.
Who sets that and how long has it been in place?
So the 255 is the national median that's out there in terms of, if you look at all states where they set their FPL, federal poverty limit, we're at 323. There's some states below 255. That's just the national median. So we thought that in terms of picking a point of which to start a premium, it's higher than it was. We work to cut it down.
That's it.
Yes, I think we all believe
That's the
that
condensed version.
to be true. The 5-point document, any further thoughts, comments, questions related to anybody around this table? Representative Telersky.
Thank you. This has been chock full, and I feel like we're just scratching the surface. You alluded to this, but I see a lot of representatives out there who they represent providers. And I think we haven't even touched the conversation on what this is actually going to mean for providers, our hospitals, substance use disorder treatment, and how this is really going to affect patients in the exam room and in the doctor's office. So at 20 minutes of 5, I'm a little concerned by just saying, does anyone have a comment? And I'm wondering if we would be able to schedule a time to actually give some dedicated conversation to the providers.
Let me consult with the division chair, but I'm sure that can be arranged. Representative Stringham.
I know there's some areas in there that I've inquired about, but in particular, I'm concerned whether there's any areas in Medicaid rates where we're seeing access issues and might be appropriate for targeted rate increases. My understanding is there's no change in rates built in to this budget despite 3 to 4% inflation rate. So each of the last 2 years. So if you want to comment on that, I'd appreciate it.
It's correct that this budget does not have rate increases in Medicaid budget. This portion of the Medicaid budget, I'm not sure what the other divisions, if they have anything. But the Senate bill, I think it was 243, had, I think, $20 million per year, but I think that was the action at the end of last week that they cut that down. So I think that's the only bill. Then there may be some other bills out there that I'm not aware of that are separate from HB 1, if you will, that have rates. I think the targets didn't allow for that.
Can you comment at all on the maternity services and how that provider network has responded to the rate increases from the last 2 years?
Well, in terms of, as you know, for hospitals, we provided a 24% increase for the larger hospitals and a 34% increase for the delivery of babies. We HB2 had the increases, the across the board increases that were given to providers for the providers, and then for the birthing centers there were two. There was before HB 2 there was an increase, and there was another increase, a part of HB 2 in 2023. There's also in that bill I was referencing, there's a $30,000 study as to what can be done more to support birthing centers in that Senate bill that I was referring to.
So are they prosperous and thriving, or are they flailing and failing?
So I think one of the, to be frank, I don't know directly, but one of the major issues I do know that was driving them to ask for higher rates was the malpractice insurance market had sort of seized for them. And part of that goes beyond what Medicaid can address.
Okay, anything further? The document of 5. Okay. The preliminary House Bill 2. I call it preliminary because, as we know, as was raised earlier, there's nothing in there. Any comment, remark, or question about anything in there now? Okay. At this point, I want to open it up to anyone in the audience who would like to make a comment, and thank you, gentlemen, so very much.
Thank you for your attention for that long a time.
I know we will see you again. From the audience? Okay. All right. If you could just make sure your microphone is on and your name is very clear and who you represent.
Sure, I'll be very, very quick too. My name is Kate Fry. I am the Vice President of Advocacy and New Futures. I really just want to underscore the comments made earlier that if we just could have more information with a crosswalk and maybe another point in time that people can, providers and those who may be impacted by these changes could bring that information forward, that'd be great, because this is all new information and it's 4:30 and 4:45 and we're all very tired. But I do want to thank the committee and the department for the presentation.
Thank you very much for your comment. Questions from anyone? All right. Yes, step right up. And again, be sure your microphone is on and your name is very clear.
Good afternoon, Dawn McKinney, New Hampshire Legal Assistance. I agree with what was just said about a public opportunity for comment. One specific suggestion, and I apologize if I missed this already because I was in and out a lot trying to go cover a couple of
Sure.
things. But I was hoping to get more information about the cost to implement some of the changes that are being suggested in terms of particularly premiums and copays. I didn't hear those implementation costs. I saw on page 39 about the implementation costs for the work requirements, for example. I would think that there would be similar costs for those other changes as well, and I just didn't hear that. So I wanted to note that for maybe if
Thank you.
there's
You're
more
referring to page 39 of the presentation today?
Right.
Okay.
That specifically outlines the cost for work requirements, but I didn't see something similar around premiums and copays. Those have got to be significantly expensive to implement administratively, and just think that that should be factored into the
Sure,
decisions.
based on the proposals that the working document that was circulated and posted
Yes.
online today. Very
Yes.
good.
Thank you.
Okay, thank you. Any questions, thoughts? All right. Anything further from anyone in the audience? Okay. At this point, I would like to remind committee members that Division 3 will meet on Wednesday, February 26th at 1 p.m. in this room. It is duly publicized in the most recent calendar. It is a budget, yes.
Don't we meet before?
No.
Okay.
Our next meeting after today is Wednesday, February 26th. So our next meeting, Wednesday, February 26th, 1 p.m. in this room. It is a budget work session for the Division of Children, Youth, and Families. We then meet after that on Thursday, February 27th at 10 a.m. in this room. Budget work session for the Division of Behavioral Health. And all of those are in the calendar for next week. So that is seeing us through next week. We're going to close with any comments or thoughts from members of Division 3. All right. At this point, then, we are going to close the work session of Division 3. Thank you all very much, and we will see you at our next work session Wednesday.